Hey, come here, come here, come here.
3 years of these webinars, and this is the fourth year on popular demand. We are continuing with these webinars. The purpose of the webinars is to share with everyone the updated evidence-based guidelines for various medical conditions. So we have covered very important topics, including in this year. And today are two very critical life-saving topics. The first is on STEMI, and the second is on emergency care in the first hour. And we have two eminent speakers with us, Dr. Madan. Welcome, sir, to our group here. We are so glad, so happy that you could make it. And Dr. Sanjeev Bhoi, I'm told, will be joining shortly. Um, Dr. Bhoi and self, we go back a long way to AIMS days. Uh, Welcome, sir.
Thank you,
Pleasure to see you.
Rajiv. It's a pleasure to
Nice.
see you.
Sir. Same, likewise, sir. So I will not come in the way of the eminent speakers here, but just to remind all our participants that over 12,000 people have already participated in it in our webinars, and over 4,000 have received certificates. My team will guide you on how the certificate uh, is issued. But broadly, there is a pre-test and a post-test which people have to attend, and they'll give you the full guidelines on how that certificate is given. So over to you, Dr. Ranjit, for carrying it forward, and Dr. Sangeeta, if you would like to say something before we.
Uh, I think thank you for coming in and introducing and supporting this program. All this is all because of the NHSRC's effort that we are able to reach out to so many people all over the country. Dr. Madan, for you, we get participants from all over India, right from district hospital, secondary hospital to primary care. And I think it would be really a challenge for you to deal with such a diverse topic, which is usually seen at a tertiary care level, but we need to because these emergencies we see at primary care level as well. So what are they supposed to do when they see these patients, diagnosis, investigation, referral, how a referral is to be done. But I think that is why we have a very good attendance also today. Uh, and plus, we have few participants from tertiary care level as well. Some specialists, have also joined us today. So, it will be a full range of participants from primary care to tertiary care level. Uh, and this has been the beauty of this program as well, because how do we implement the standard treatment guidelines at the ground level, keeping their resources in mind, infrastructure in mind, because they may not have all those facilities at the ground level, may not be having all the investigations as well. And the referral, the first referral facility may be far away, taking few hours for the patients to reach the PCI center, enable center, where these patients with acute coronary syndrome can be duly treated. So and also the emergencies, today's topics are very important. Emergencies, how do you deal with this? What are the prioritization to be done? How do you handle bleeding patient, shock patient that has come to you? So these are all very important emergencies, and um, many of us feel that we need to know more, or think that we will not be able to handle. But the frontline workers management stabilization is a very important um, uh, for the outcomes, good outcomes to be observed. So right now they are doing a pre-test. I think quite a few have already done it. We'll wait for 5 more minutes for them to finish this pre-test. Already, I think 70 people have already done, but we have around 200 people here. Some of them have joined from a hub where more than one participant is attending. So actual attendance may be more.
So, Dr. Sangeeta, I'm happy to share that the demand for the STG webinar is so high that the various divisions in NHSRC also, they said somehow we have not been able to participate. So this time they have also been invited. वो दिए तले अंधेरा था. So they have also joined in this time. And I extend a very warm welcome to all participants from NHSRC as well.
I do try to, disseminate the program information from all my channels. And NQuas, we have a NQuas SSRs group also. So, I put this link information there in that NQuas What's group also. So maybe if you have more channels, they can also join.
Certainly, yeah. I've shared it with the AHA group also, and then our participants, they also keep forwarding it to their contacts because they see value in it. And then they move it and they share it with others as well. Um, Dr. Ranjit, are we ready to
Sir,
uh,
5 minute, अभी 2-3
okay,
मिनट
so
और
in the
wait.
meanwhile, Dr. Sangeeta, I see a very young and curious person who's joined the
Yeah.
webinar. So
She's my
maybe you would like
granddaughter.
to.
she's
Yeah,
she's my granddaughter.
right. So yeah, she's the youngest participant in the
Yeah,
webinar. Yeah.
youngest participant today. Last time this topic was taken by Dr. Vijay Trehan, and he was demonstrating heart, beating like this, and she was observing that, after that, if you ask her, she's like, heart beats like this, sometimes it goes wrong like this.
So maybe we do hope that this attending this webinar will stimulate her to
Yeah,
uh,
she's very much
join the
fascinated.
fraternity as well.
Yeah, she's very much fascinated by this.
Yeah. Um, Ranjit, maybe we can introduce the speaker in the meanwhile.
Yes, sir. Am I audible, sir?
Yes.
Yes, yes.
Uh, Good afternoon, everyone. On behalf of Quality and Patient Safety Division, National Health System Resource Center, New Delhi, I welcome all our participants, and I also welcome our expert speaker for this session. First session is on STEMI. Circle. Our first speaker is on is Dr. Hemant Madan sir. He's a medical graduate from Armed Force Medical College, Pune. He's also fellow of the Royal College of Physicians, London and Edinburgh, and fellow of the Society for Cardiovascular Angiography and Intervention, USA. He served as a senior advisor and head of the Department of Cardiology till 2015 in AIMS, Pune. Dr. Madan is also a recipient of Vishisht Seva Medal by the President of India in 2015. He served as a director cardiology and unit head in Fortis Hospital from 2015 to 2017. And currently, sir is associated with Narayana Health and heads the entire cardiac science program, including cardiology, pediatric cardiology, electrophysiology, cardiac surgery, and cardiac anesthesia. Requesting you to, sir, enrich our participants with your expert knowledge on this topic. Welcome, sir.
Uh, Thank you very much. And Dr. Ranjit, are we okay to go, or should I wait for another 3-4 minutes?
I think we can start now.
We
Sir,
can
you
start
can
now.
Yeah.
So I'm very grateful to Dr. Rajiv Patni, with whom I go back many, many decades now, for having introduced me to this wonderful forum. To Dr. Ranjit Mandal, who actually coordinated this entire talk. And Dr. Sangeeta, it's a pleasure to meet you, even though it's online, and also to meet your granddaughter as a as an added incentive. So I'm going to talk. This is a rather informal talk, and I would request all participants. I would encourage all participants to interrupt me with their questions by way of either putting it on the chat, or if there is something that you would like an immediate clarification on, please uh, stop me and ask me a question right then and there. Uh, I would also like to kind of encourage you to take notes and keep some tips in your ready for as a ready reckoner. As you are all aware, despite all progresses in the field of cardiology, cardiovascular death still remains the single most important cause of death. The data from both urban and rural populations continues to show that we have still not been able to get rid of this menace. While we have been gradually increasing our penetration of interventional cardiology, increasing penetration of tertiary healthcare, what has simultaneously started happening is that the diabetes epidemic has virtually taken us off guard. About 2 decades or 3 decades ago, we did not anticipate and we did not envisage that diabetes will be such a big problem. But now we know that we are sitting on the peak of epidemic of diabetes. We are probably another 2 decades away before we are able to reverse the whole process of diabetes. Reverse means I don't mean reversing diabetes as a disease, but reversing data regarding diabetes with various lifestyle modifications, with various governmental regulations, which we hope will start uh, taking effect. But hopefully, with till that time, we have to deal with this whole menace of diabetes and its attendant complications. And cardiovascular complications remain foremost among all complications of diabetes. And when we talk of cardiovascular complications, the one complication which kind of makes us more afraid, or which kind of scares us the maximum, is this disease called STEMI. For most of us are aware of the full form, but I will just go a bit into the history of what STEMI and how this uh, terminology came into being. See, earlier, if you remember, acute myocardial infarction was acute myocardial infarction, and unstable angina was unstable angina. There was no term like an ST elevation MI. When we were medical students, the term used was acute myocardial infarction. Somewhere about 3 decades ago, in the late, say, 1990s or early 2000, this realization came about that you can have a myocardial infarction with elevated cardiac enzymes, but without ST elevation. And you could also have, very rarely, that was very rare, but you could also have the reverse. You could have ST elevation, but you may not have cardiac enzyme elevation. Now, why did we want to differentiate this was that we realized that treatment of both was slightly different. That is, ST elevation MI and non-ST elevation MI, their treatment was slightly different. And secondly, ST elevation MI had a very high incidence of mortality. So therefore, people thought that it is better to differentiate acute myocardial infarction, or now as they are called as acute coronary syndromes, into ST elevation MI or non-ST elevation MI. ST elevation MI is something which is characterized by ST elevation on an ECG. That is the term, that is why it is called ST elevation MI. Normally, ST elevation MI is of two different types depending on where the ECG changes take place and therefore corresponding to the artery which is involved. ST elevation MI in anterior leads, which is V1 to V6, is called anterior wall ST elevation MI, and ST elevation in lead 2, 3 AVF, which is the inferior leads, is called inferior wall ST elevation MI. Now, when we look at the ECG and we find that there is ST elevation MI in anterior leads, that is V1 to V6, we approximately know that in this patient, it is the LAD or the left anterior descending artery of the heart which is involved. And if it is in inferior leads, we know that it is either the right coronary artery or the left circumflex artery which is involved. Of course, left circumflex artery also supplies the lateral part of the heart, and therefore it may not only be inferior wall, but it may be something called an inferolateral MI. But at a PHC level, at a level of a primary healthcare facility, suffice it to say that if we are able to differentiate LAD or anterior wall MI from a inferior wall MI, we are happy with this. The reason why we say this is that inferior wall MI has a different set of complications and anterior wall MI has a different set of complications. I find one participant has asked if there is a PPT, and my answer to that is an emphatic no. There is no PPT. I'm afraid and I'm sorry, but you will have to see me and listen to me. I'm not a very great believer of PPTs when you're explaining topics. I think direct communication helps us better. In PPT, one generally tends to overemphasize on a few points and tends to ignore a few others. So having said that, so I've differentiated anterior wall from inferior wall MI, which is the first thing that any doctor should do. There's somebody who has asked a question, what is it when it is lead 1 and AVL? Lead 1 and AVL technically look at the lateral side of the heart, and therefore it is a lateral wall MI, or what is also known as high lateral wall MI. Now, what we are trying to differentiate is we are trying to identify which artery is which artery is involved by looking at the ECG, and these findings are fairly accurate. If you have only a lateral wall MI, the artery involved is likely to be either a branch of the circumflex, which is called the obtuse marginal artery, or it is likely to be a branch of the LAD, which is called the diagonal artery. If you have only isolated ST elevation in lead 1 and AVL, but you can have some variations in this depending on the size of the vessel and depending on the distribution of the vessel, but these are broad generalizations. So I was telling you that it is important to differentiate anterior wall from inferior wall, basically because you know that a set of complications anticipated in anterior wall MI is slightly different from a set of complications involved in inferior wall MI. To give you an example, anterior wall MI is a more dangerous kind of MI. It is LAD is the artery which is also called the widow's artery because it causes more deaths, particularly in males. So that's why it's called the widow's artery. It leads to a much larger area of myocardial damage, and therefore incidences of ventricular dysfunction, incidences of ventricular tachycardia, sudden cardiac death are far more in an anterior wall MI. When we talk of inferior wall MI, right coronary artery is the artery which supplies the conduction system of the heart, which supplies the AV node of the heart, and therefore complete heart block and electrical complications of the bradycardia kind are much more common in an inferior wall MI. So that is why it's important to know which artery is involved in a particular myocardial infarction. So this is the first step of identifying the artery involved. The second step is to understand what is the current management of myocardial infarction, which is what this talk is all about. Current management in, say, the first 1 hour, 2 hours, and first 6 hours of myocardial infarction. For that, you must go a bit into the history of myocardial infarction treatment and know why we have reached a point where we have reached. To give you an example, there was a past, when we look at 30 or 40 years ago, myocardial infarction used to carry a mortality rate of about 30%. That means 1 in 3 people with a myocardial infarction would die. The mere establishment of CCUs, the mere establishment of ICUs and CCUs, or ICCU as you may call it, reduced the mortality from 30% to 15%. It halved the mortality. Why did mere ICU reduce the mortality? For a very simple reason, that a majority of deaths which happen in the first 24 hours are deaths due to arrhythmia, due to ventricular tachycardia. So if you admit a patient in ICU and put him on a cardiac monitor and you just have a defibrillator, you have no other medicine, you have no thrombolysis, you only have a defibrillator, you will reduce mortality of myocardial infarction from 30% to 15%. So you will half it. The next major gain came by thrombolysis. Thrombolysis or clot buster medicine, which came around in late 1990s, actually in late 80s, but the usage in India became established more in 1990s. When thrombolysis came, the mortality was further reduced by another half, so it became around 7.7 to 7.5%. So the next major step came when we when we started dissolving clots and opening up arteries. With the thrombolysis experience, it became very clear that opening arteries in acute myocardial infarction helps. If you are able to somehow open the artery, the myocardial infarction effect will go down, the complication rates will go down, and you will save lives. Then cardiologists started thinking, is there another way of opening arteries other than just relying on thrombolysis? What you need to understand is that the success rate of thrombolysis, even in the best of situation, the success rate of thrombolysis is only about 60 to 70%. That means a clot once formed, in about 30 to 40% of the time, the clot won't dissolve even if you give full dose thrombolysis. It will vary a little bit depending on how soon a patient has come. The success rate of thrombolysis may be a little higher if you give it in the first 2 hours or so. 2 to 6 hours, it is not as much, but after 6 hours, it is virtually worthless. And as you can understand, many patients in India do not reach a hospital within the first 6 hours. They are usually late, and therefore thrombolysis may have limited application or limited role if you were to compare it with angioplasty. If you are in a situation where there is no angioplasty, situation is different. But if you are in a place where an angioplasty is there, then these rates cannot be compared. So as I was telling you, in the early to late 90s, the thought process started veering towards, can we open this artery? It's called an IRA, or an infarct related artery. Can we somehow open this artery mechanically? That means without any thrombolysis. Is there a way by which we can open this artery by mechanical opening of the clot? Remember that in the late 1990s, actually acute myocardial infarction was a contraindication for angioplasty. If there was in that era, it may sound very surprising now, but in that era, uh, this was acute angioplasty was meant only for chronic blockages. It wasn't meant for acute blockages. It started having a meaning for acute blockages only in the late 1990s. And by early 2000s, by 2003, 2004, it was definitely realized that angioplasty was the way forward for opening a blocked artery. And to be very honest with you, the mushrooming of interventional cardiology actually happened when it was realized that even in acute coronary syndromes, there was a huge role for opening up blocked coronary arteries. So the third development, if you remember, I was telling you mortality rate from 30% to 15% by establishment of CCUs, from 15% to 7.5% by thrombolysis. The third major gain came when balloon angioplasty started getting done for acute myocardial infarction. This reduced the mortality from 3.5 or 4% to roughly half to about 2% if one opened up the artery by a balloon angioplasty. After balloon angioplasty, a further refinement happened when we started using stents in acute myocardial infarction. The first major trial for stents was a trial called the Admiral trial. But after that, many trials have been done. And thereafter, the mortality rate of acute myocardial infarction was brought down if a patient reached the hospital in time. See, there is a lot of time variation in this, but for a patient reaching the hospital in time, the mortality now would stand around 2%, 1.5 to 2%, depending on the type of vessel involved and things like that. But that is a substantial gain from the 30% mortality where we were about 4 decades ago. So that's the important thing of why opening up an artery is important. Now, when you are at a primary health center level, or when you are at a level where uh, angioplasty or an intervention is not possible, or where a cardiac services are not available, or even if a cardiologist or a cardiac service is available, is it likely, how do you manage these cases? So there are 2 or 3 points that I want to make here. These points are also appearing as questions, so I'm going to address these questions during the conversation. The first point is being reasonably accurate in diagnosing acute myocardial infarction. Can you get myocardial infarction without chest pain? Can you get myocardial infarction with atypical chest pain? Can you get myocardial infarction with a routine normal ECG? Can you have myocardial infarction with atypical ECG changes? Can you have troponin elevation without any uh, ECG changes? So there are different variations to this whole theme, and I personally think that despite all advances of medicine, all increasing penetration of education, increasing availability of ECG machine, myocardial infarctions are still missed by the primary healthcare physician in about 15 to 20%. It sounds like a large figure. That means we are still missing 1 in 5 myocardial infarctions. I'll tell you why we miss them. The first thing is atypical presentations. Our standard learning is that myocardial infarction is associated with chest pain in the middle of the heart, crushing chest pain, heaviness, marked sweating, low blood pressure, things like that. Now, let me tell you that all this is what the book picture describes for us. There are lots and lots of variations in this theme. The first variation is a predominance of gastric symptoms in India. There are lots and lots of patients who do not have the classical cardiac symptoms. They have gastritis or gastric-like symptoms, particularly in inferior wall MI, but I've noticed this even in anterior wall MI. So therefore, don't go away with the impression that gastric symptoms only happen in uh, inferior wall MI. They can also happen in anterior wall MI. In fact, there is a predominance of these symptoms in an Indian subset of patients. So patients sometimes they self misdiagnose. That means they self take Eno or take Digene or take Pantocid multiple times on, and only on day 3 or day 4 they realize that my symptoms are not going and therefore I must pay attention. When they come, you realize that they've had an infarction. Similarly, vomiting, sudden onset vomiting is a very important feature of myocardial infarction presentation among the atypical subset. The third symptom, which is often, we are taught about all this in books, but it is often missed, is sudden onset of breathlessness. You'll be surprised, but even in my hospital, which is supposed to be a tertiary care hospital based in Gurgaon, which is supposed to provide one of the best healthcare facilities in the country, many times patients presenting with acute dyspnea are admitted under the pulmonologist but not under the cardiologist. Only when 2 days later or 1 day later, our pulmonologists, who are very respectable colleagues, they send a routine, what is called as a breathlessness profile or a dyspnea profile, which includes troponin T, CPK-MB, and NT-proBNP in our center. They find that the troponin is elevated. So sheepishly on day 2 or day 3, we are involved to say, sir, shayad ye myocardial infarction hai. He's erroneously got admitted under me. So that is the second atypical presentation, breathlessness, which we have missed. The third atypical presentation is again something which is under recognized, is an acute or a sudden onset of marked fatigue. What you need to understand is that any symptom which occurs suddenly, you need to pay attention to this. Any patient who is chronically fatigued, he's a different subset. But suppose a person comes to you and says कि डॉक्टर साहब मुझे पिछले 3-4 दिनों से थकावट बहुत हो रही है. I can't do routine work which I'm not able to do, which I was able to do earlier. Please get an ECG done for that. Before ECG is a very basic investigation. It's available across the spectrum. Now you have portable ECG machines. Please include ECG as a routine investigation. So these are the 3 atypical symptoms that I was wanting to talk about. In addition, as I told you, about 80% will have classical symptoms. There's no difficulty in diagnosing. About 20% will have these 3 will have these 3 atypical symptoms. One is gastric symptoms, second is breathlessness, and third is marked fatigue. What is the incidence of pure silent myocardial infarction? There is a term which all of us hear about, which is called silent myocardial infarction. Now, silent myocardial infarction is, we all read in books that diabetics have a higher incidence of silent myocardial infarction. It's true, but you must remember that there are 2 types of silent myocardial infarctions, type A and type B. Type A is silent myocardial infarction where a patient actually doesn't have any symptoms. That means he's just silent. He undergoes an echo for a routine evaluation for something, for preoperative assessment, for some other medical exam or an ECG, and you find that he's had a myocardial infarction. Type A silent myocardial infarction with no symptoms is extremely rare. Even in diabetics, it is rare. Most diabetics will have some symptom. It may not be classical pain or discomfort, but some symptom will be there. Type B is what I just alluded to. Type B is those patients who do not have typical symptoms, but they have some kind of discomfort. That is type B. And type B is fairly common. Type B is not rare. Type B is atypical symptoms. I told you it's about 20%. People will have various different kinds of symptoms, but they will have some symptoms. Completely silent myocardial infarction is extremely rare. To go into the neurological basis of it, it used to be said that many diabetics have associated autonomic neuropathy, and when you have autonomic neuropathy, you do not get pain, and that's when you get silent MI. But telling you from practical kind of practice, it's not something which you find very commonly. Now coming to the diagnosis of myocardial infarction as a primary physician or even as a specialist in a small hospital. The diagnosis of myocardial infarction has traditionally been made on three, uh, three parameters. The first parameter is patient symptoms. The second parameter is ECG, and the third parameter is cardiac enzymes. But you need to understand that all these three will have their own limitations, and therefore we often say that presence of two out of these three parameters is enough for you to label a patient as a myocardial infarction. So symptoms I've already talked about. I've talked about atypical symptoms. The second is ECG. I told you the classical ECG changes are ST elevation in two or more concordant leads. When we say two or more concordant leads, what it essentially means is that in the territory which you feel is getting infarcted, if you have, like in inferior wall MI, there are three leads: lead 2, lead 3, lead AVF. Out of these three leads, if you have ST elevation in two leads, that is enough for you to diagnose myocardial infarction. Similarly, in anterior leads, we have V1 to V6. If you have any ST elevation in two leads, that means V1, V2, V2, V3, V4, V5, that is enough to diagnose as myocardial infarction. Is there a definition of diagnosis? Yes, there is a definition of diagnosis. The first uh, thing is that the ST elevation should be convex upward elevation. It should not be concave upward elevation. Second, the ST elevation should be more than 2 millimeter in chest leads and more than 1 millimeter in limb leads. As you know that when you do an ECG, there are a total of 6 limb leads and 6 chest leads. So if you're talking of ST elevation in V1 to V6, it should be more than 2 millimeter. And if it's in lead 1, 2, 3, AVR, AVL, AVF, it should be more than 1 millimeter. So that is the defining criteria of ST elevation as far as diagnosis of MI is concerned. Two or more concordant leads, ST elevation of a certain degree. Are there any confusers in an ST elevation situation? Yes, there are confusers. I want you to remember two or three confusing kind of, kind of differentiators or differential diagnosis. The first is acute pericarditis. Acute pericarditis can cause ST elevation. It can cause myocardial injury and therefore lead to troponin or CPKMB elevation. And it can also cause chest pain, as you are aware. So how do you differentiate? The first thing is myocardial infarction by and large is associated with some kind of febrile inflammatory illness. So therefore a history of fever preceding chest pain argues more in favor of pericarditis. The second is the type of ST elevation. The type of ST elevation in pericarditis is usually a concave upward ST elevation and not a convex upward. Concave upward ST elevation is more in favor of pericarditis. The third thing is that ST elevation in pericarditis is not concordant. That means you may get ST elevation in one or two leads, or you may get ST elevation in all leads. In myocardial infarction, naturally, because it is an artery which is involved, it will be in some area, it will be in some territory. Very, very rarely will you get multivessel myocardial infarctions. Usually it is either inferior wall or anterior wall. Whereas pericarditis, because it's an inflammation of the entire bag covering the heart, The inflammation can happen in all around pericarditis, and therefore it tends to be more diffuse changes. The nature of pain of pericarditis is also slightly different. It is positional. It is more of a localized pain. It can be associated with a pericardial rub and all that. I don't think that's a topic of discussion right now, but suffice it to say that you need to differentiate it from pericardial ST elevation. The second ST elevation that you need to worry about, which is very common in Indian subset, is something called the early repolarization syndrome. Asian subset of patients have something called the early repolarization syndrome, which is because of potassium channels, and therefore young athletes can have ST elevation in V1 to V2, which is a concave upward ST elevation, which is not like a myocardial infarction at all, may not be associated with pain. But when I was in the services, I would often have young recruits or young Jawans who would be referred to me with a diagnosis of acute myocardial infarction because they had early repolarization syndrome. The way to differentiate this is, if a patient is asymptomatic, just ask him to walk a little bit and the ST elevation settles down when he walks. When with a slight increase in heart rate, the ST elevation settles down, and that is a classical early repolarization syndrome. Now we come to proper management of myocardial infarction at a primary level, at a secondary level, and of course at a tertiary level. We all know that if you have access to a tertiary level, angioplasty and stenting is probably the best that you can, that you should get. When a patient comes to a primary healthcare setup, what should be given? The first drug, which of course has to be given, is aspirin. Ideally 300 milligram of aspirin. Mode of administration doesn't matter too much. Mode of administration, whether you give it chewable form, whether you dissolve it in water, that is all vehem. You must give aspirin. That's the most important thing. Now there are several other attendant drugs that we talk about and whether they should be given or they should not be given. The second drug, which is often given along with aspirin, at least in good centers, is another antiplatelet drug which is called clopidogrel. So should you give clopidogrel? Yes, if you have access to it, because the entire process of myocardial infarction, remember, is a process of thrombosis. It's a process where platelets are terribly activated. So you need to suppress platelet activation. So the second drug which you can and you should give is clopidogrel. The dose is usually 4 tablets of 75 milligram each. So 300 milligram of clopidogrel should be given. Now the third thing is, should you give heparin or should you not give heparin? Well, heparin, you should give heparin if a patient is likely to take some time to be transferred to a cath lab, or if a patient is likely, or if even if you're in a cath lab center, activation of the cath lab will take some time. In the best of centers, including the best of institutes, no matter how hard you try, invariably waiting time of about 45 minutes to 1 hour is there if a patient comes off working hours. Now, in these situations, it is better to give heparin. The doses is about 5,000 units intravenously, not subcutaneously so much. Intravenously is better to start the process of anticoagulation. Now comes the fourth drug which is to be given, that is beta blockers. Should you give beta blockers? Should you give metoprolol or should you not give metoprolol? It entirely depends on 2 or 3 things. One is, what is the blood pressure? Does blood pressure permit you to start beta blockers? If the blood pressure is high, if the heart rate is high, beta blockers are good drugs to be given. You can give any beta blocker. You can give IV esmolol if you have. You can give intravenous metoprolol, slow aliquots of 1 milligram each if you have. You can give oral metoprolol if you have oral metoprolol. Beta blockers should obviously be avoided if the blood pressure is borderline, if the heart rate is borderline, or if patient has extensive pulmonary edema, crepitations, and beta blockers are naturally contraindicated because they can worsen pulmonary edema. But otherwise, beta blockers are extremely good antiarrhythmics. They have anti-ischemia effect. They reduce the myocardial oxygen demand. So if there is no contraindication, you can and you should give beta blockers. I'm sure some of you will have this doubt. What about thrombolysis? Should you give thrombolysis? You should not give thrombolysis. Should you kind of somebody has asked me in between, what about statins, sir? I'm going to talk about this. I'm as of now, I'm still talking about drugs which reduce the thrombosis component. So should you thrombolize or should you not thrombolize? Well, I had personally done a study on this, which was titled "Transfer for Myocardial Infarction, Safe and Effective." This was when I was in a non-cath lab center, but we had cath lab access to cath lab facilities anytime between say 1 to 2 hours away. Now, this question always struck my mind: should you transfer to a cath lab center or should you thrombolize there and then itself? There were two very large trials, incidentally, European trials, which addressed the same issue. They were called the Parag and the Paragon trials, which this is, I'm talking of late 1990s and 2000, which tried to analyze whether it is safer for patient to be given thrombolysis or to be transferred to a nearest cath lab center. And these trials conclusively proved, and the same was the result from my data, to say that transfer of patients was a far superior option than giving thrombolysis. Therefore, if a patient can be transferred to a cath lab center in say 1.5 hours, it is safer, it is better to transfer a patient for a angioplasty than to keep them and thrombolize them. I'll tell you the reasons for that. One is most thrombolytic agents have uh, a complication rate in the form of hypotension, in the form of increased bleeding complications, and some of the older ones like streptokinase and all obviously have allergic phenomenon. That is reason number one. Reason number two is something which I already told you. Even in the best of settings, thrombolysis will achieve a success rate of only about 60 to 70%. So that's the second problem with thrombolysis. The third problem with thrombolysis is that doing an angioplasty, even if you are, suppose, one of you could ask me that why not thrombolize and then send him for an angioplasty? This would give him the best of both worlds. You're covering up that 70% chance, and if 30% he doesn't open up, you can always open it up mechanically. The reason is that complication rates, including bleeding rates, including stent related complication rates, are higher when you have already thrombolized a patient prior to his being taken up for angioplasty. If I was to take up a patient for an angioplasty without him receiving thrombolysis, the results are better. Complication rates are higher if he has already been thrombolized. So then do we not do, or should we not do angioplasty in patients who have received thrombolysis? This answer is a bit kind of, it's a nuanced answer. It's not a straightforward answer. One must do something called a rescue angioplasty. Suppose you thrombolize and you find that his ECG has not settled down, he continues to have pain. In these patients, we do something which is called a rescue angioplasty. That means you are aware that this patient, his artery has not opened up, and therefore we must take a chance and we must open up the artery even if the bleeding complications are higher. But if the bleeding complication, if he has settled down, suppose the ECG has settled down, he has no pain, in these patients, angiography should be referred by at least 24 to 48 hours before doing a angiography to see if the artery has opened up or not. So this is about treatment of blood thinners and referring them for angioplasty or referring them for a procedure. So the take-home message for you from this discussion, it's not the total take-home message, whether we should give thrombolysis or we should refer a patient for angioplasty. If a patient has no kind of referral issues, if he is stable, it is better to refer a patient for an angioplasty. And if the referred center is anything between 1 to 2 hours, it is quite safe to refer patients for an angioplasty. Obviously, in a cardiac care ambulance, obviously with an onboard transfer doctor with a nursing team, so that if there is a complication, it can be handled on the way. Now, I'm sure there are lots of drugs which you come across and which we use off the cuff, whether we should use or not. We'll discuss each one of them threadbare. What is the role of high dose statins? We all give high dose statins in an acute myocardial infarction now, whether they should be given or they should not be given. High dose statins like atorvastatin 80 milligram or rosuvastatin 40 milligram has now become universal in management of acute myocardial infarctions. The reason is that we now know that there is also an inflammatory component to acute myocardial infarction. And statins not only have an anti-inflammatory role, they have a strong anti-inflammatory role, but they also have an anti-platelet role. And therefore, we should give statins as an add-on to the other two drugs which I said, aspirin and clopidogrel. The second is, should we give nitrates? Nitrates, I'm afraid, have gone out of utility in terms of management of myocardial infarction. The reason why I say this is that we now know that myocardial infarction is the coronary spasm component is very, very little in a myocardial infarction. It is essentially a thrombosis component, which is the strongest component. And therefore, if you have to treat it, the thrombosis component has to be treated more than any coronary spasm. The other thing is sometimes coronary nitrates will produce hypotension. They will worsen the coronary ischemia by producing hypotension. The third reason is that many of these patients of myocardial infarction, even though they have blockage in one artery, they thrombosis in one artery, they also have blockage in other arteries. By producing coronary vasodilatation, they can sometimes produce a steel-like phenomenon and therefore may actually precipitate ischemia in other arteries. So generally, nitrates as a modality of treatment have fallen slightly out of favor when we talk of treatment of acute myocardial infarction. It is no more a universal drug to be given. On the contrary, if some patients of myocardial infarction present with very, very high BP, with accelerated hypertension. So on the contrary, instead of giving sublingual sorbitrate, intravenous nitroglycerin NTG infusion is an extremely good drug to control blood pressure and to be given during an acute myocardial infarction if the blood pressure is high. The advantage of IV nitroglycerin is that you stop it and within 1 or 2 minutes, the effect goes off. So, if the BP falls or if there is a drop in the blood pressure, it's very easy to control the blood pressure with nitroglycerin infusion. I'm sure all of you have heard there is a newer drug called ticagrelor, which is available in various brand names. Whether there is any use of ticagrelor in acute myocardial infarction, ticagrelor can be used as a replacement for clopidogrel if it's available. The bolus dose is 180 milligram. Ticagrelor is generally preferred if a patient is certain to go for a coronary intervention. If a patient is going for a coronary intervention, ticagrelor is a drug of choice. But if ticagrelor is if a patient is not going for a coronary intervention, and if you do not have ticagrelor, don't bother, give clopidogrel. That is an equally useful drug. Somebody else has asked me on what is the dose of nitroglycerin. The dose of nitroglycerin, you generally start with about 5 micrograms per minute, but you can go on increasing it to 10 to 15 till the blood pressure comes under control. I am repeatedly saying that this drug is essentially used for the hypertension component and not so much for the ischemic component. Somebody else has also asked what is the loading dose for more than 60 years of age. I'm presuming that this is the loading dose for clopidogrel. Correct me if I'm wrong. Loading dose for clopidogrel remains more or less same, 300 milligram, that is 75 milligram ka 4 tablets. Ticagrelor, is it better than clopidogrel? Yes, it is better than clopidogrel. Can we use low molecular weight heparin instead of heparin? Of course, you can use low molecular weight heparin instead of heparin. A slight kind of, theoretical advantage is that heparin has an antidote which low molecular weight does not. But then that's all right. If you have Clexane or if you have enoxaparin, dalteparin, you can use, or Fragmin, you can use any one of these. Is there any minimum gap duration between thrombolytic therapy and rescue angioplasty? No, there is theoretically no gap. No gap. If you have thrombolized, thrombolysis will normally take about an hour to administer. If you administer thrombolysis and if you find that a patient has no relief for another hour or so, he must be subjected to a mechanical opening of the infarct-related artery. I'm sure all of you are aware, but somebody can ask you, are there any kind of deviators? I'm going back a little into the diagnosis of myocardial infarction. Are there any deviators from the universal theme of enzyme elevation? Yes, there are deviators. The first deviator is if you do a cardiac enzyme test too early, if you do it, say, within 6 hours or so, you may get a normal level of troponin, and therefore if the index of suspicion is very, very high, you must repeat another test after 6 hours or so of the index pain. So that is something that you must remember. A CPKMB also takes about the same time to get elevated. So both these tests may not be elevated if a patient has reached very early on. Similarly, can you get a falsely elevated troponin? Yes, you can get a falsely elevated troponin, particularly in patients who have kidney disease. Sometimes you find that the creatinine is 2.2 and the troponin is about 25 or 30. Now, this is classically a troponin elevation due to associated kidney disease, and therefore, when you get elevated troponin levels, you must look at the kidney function along with to see whether there is associated kidney disease or not. Can you get a myocardial infarction with an absolute normal ECG? Yes, you can get a myocardial infarction with an absolute normal ECG, but it is rare. Usually you will have some subtle findings. However, there are areas of myocardium which are hidden areas, and therefore you may miss a myocardial infarction in these situations. One of our teachers used to say very clearly that there is nothing called silent myocardial infarction. It is just that you're not hearing or you're not looking for it well enough. So if you look for it well enough, you will find myocardial infarction activity in some way or the other. But there are 2 or 3 territories where you can miss a myocardial infarction. The commonest area which is missed is something called a posterior wall myocardial infarction, also called a true posterior wall myocardial infarction, which is usually seen in circumflex territory MIs, where the posterior wall of the heart is infarcted, and the way to diagnose it is to do normally we do up to V6, go back, do V7, V8, and you will find as you keep going posteriorly, you'll see ST elevation in those leads. So true posterior wall myocardial infarction. The other thing is that because they have ST elevation in posterior leads, they may have ST depression in anterior leads. So if you have classical symptoms with enzyme elevation and you have ST depression in anterior leads, you must look for it by doing posterior leads to diagnose a true posterior myocardial infarction. Similarly, right ventricular infarction is difficult to diagnose. Right ventricular infarction is also rarer, but if you have right RVMI, the way to diagnose is to do something called a V3R and a V4R, which are mirror images of V3 and V4, but on the right side. So if you do a V3R, V4R, you will find an ST elevation in those leads. Just remember that RVMI ECG changes are very transient. Therefore, if you may, they may last for less than 1 hour or less than 2 hours. So therefore, if you need to diagnose V3R, V4R MI, that means right ventricular MI, you must look for it very early on. So I've covered silent. Yeah. The final thing is, there are two more aspects which I wanted to cover. The first is an aspect of there was a teacher of ours who used to ask us a question that suppose you suspect 10 myocardial infarctions in patients in the emergency, 10 different patients, and you have 10 patients with myocardial infarctions. You transfer all of them to ICU and you realize that all 10 actually have myocardial infarctions. So what would you say about the clinical acumen of this particular doctor? Is it a good clinical acumen or is it a bad clinical acumen? By the nature of this question, obviously, one would be tempted to say that he's an excellent doctor because he diagnosed 10 MIs in the emergency and all 10 have MIs. The realistic answer is that it is a poor clinical acumen because his index of suspicion is too low, too high. If you have an index of suspicion which is very high, you're only diagnosing typical cases of myocardial infarction and you're likely missing atypical cases or cases which are myocardial infarctions but have atypical findings or atypical presentation. Therefore, you need not worry if you've wrongly diagnosed. Even when I was a medical officer, I would be hesitant कि इसको transfer करें या ना करें. If I transfer, what will the doctor in the larger center feel? कि इसको myocardial infarction नहीं आता? Please do not worry about this. Even if you label a patient wrongly as myocardial infarction, it doesn't matter, but have a low index of suspicion because that's the only way to benefit patients. The second thing is whether you should thrombolize on a atypical chest pain or on a pain which you think is myocardial infarction, but actually it's not myocardial infarction. Again, people have analyzed the beauty about modern medicine is that people have analyzed everything. So there were very large myocardial infarction trials which were called the Gusto trials. And they found that even in Gusto trials, the incidence of false thrombolysis, that means wrongly thrombolizing a patient, was about 9%. That means if you thrombolize 100 patients, about 9 of them were actually not myocardial infarctions, but you thrombolized them. And it was found that no real harm was done to these patients. Other than, they may have transient excessive bleeding through the IV lines and all that, but you're not harming anybody. Therefore, my suggestion and my request to each and every one of you is that if you want to be a diligent doctor, if you want to be actual kind of, if you want to be thorough with your practice of medicine, have a low index of suspicion, transfer patients as soon as you can, and ensure that they are treated with some form of a therapy which will open up arteries. Eventually, you must remember that there is no other solution than opening up an artery for treatment of an acute myocardial infarction. I'll just address the last question because I can see Dr. Sanjeev Boy is already online. The last question is about analgesic of choice if morphine is not available. Well, you can use anything. Morphine was also an overrated drug. It's a narcotic analgesic. It produces a little bit of hypotension. It produces drowsiness, which is often not desirable. Therefore, any drug which you have, people will respond to tramadol. They will respond to any analgesic that you have. Sometimes we in the cath lab, before any analgesic is given, we just give a paracetamol infusion and kind of deal with this. I can also tell you that sedation is hardly ever needed in myocardial infarction. In fact, in some cases, in an interventional center, in some cases it is counterproductive. Therefore, do not sedate patients needlessly. That old concept of sedating them, keeping them virtually kind of on a bed, all that is now gone. Now the entire emphasis is that you open the infarct related artery as soon as you can. Dr. Sanjeev, I'll take just 1 minute of yours to answer the last question. Troponin T versus troponin I. Is there any preference? No, there is no real preference. Troponin I is usually available to us as a quantitative test, so therefore we can quantify the size of myocardial infarction based on troponin I. Troponin T is more of a qualitative test, a yes/no strip test. So if whatever you have, you just rely on this. Don't bother too much about these specifics. With this, I'm going to end my talk, and if there's anything that you need to answer, that you need me to answer, please go ahead. I don't know if I
Dr.
have any
Madan,
more.
yeah, thank you for a wonderful description, right? And demystifying this treatment of STEMI elevation. Because since we have a lot of participants from primary healthcare, could you just also, highlight on transfer, how the transfer referral should be done, and what is the role of oxygen here? You know,
Very, very, very pertinent question, madam. I forgot to touch about oxygen. So your second question is something that I'm going to answer first. Oxygen is rarely, oxygen is a good supportive system to have, in the sense that you give him some oxygen through nasal prongs. Whether it does anything, what we are talking of here is tissue hypoxia. We are not talking of uh, lung hypoxia. We are talking of whether it's actually going to increase tissue perfusion, tissue kind of oxygenation. What we need to understand here is that tissue hypoxia in an ischemic setup is due to a blockage in the blood supply. It's not that the blood is carrying less oxygen. So when there is no blood supply, the paradigm has to be that we need to open that blood supply. So therefore, oxygen is a good add-on to have. It will improve oxygenation in an acute LVF kind of a situation. But if there is no LVF, suppose without oxygen, the patient's oxygen saturation is 99 or 100%. Many patients with inferior wall MI actually will have normal oxygen saturation. In these patients, adding oxygen does not help at all or does not make any difference at all. But if on the contrary, you have a patient whose oxygen saturation is 90, 91, 92%, in these patients, these will help. After COVID, almost all clinicians carry a pulse oximeter in their pockets. So it's a good idea to have, a pulse oximeter, measure oxygen. If the oxygenation is all right, leave it. I'll give you a practical, problem that happens with trying to oxygenate a patient. Even in my hospital, there are many times that the transfer oxygen cylinder, like, Rajiv will bear me out, many a times transfer oxygen cylinder जो है वो खाली पड़ा होता है. There's no, the patient has to be transferred from my emergency, which is on the ground floor, to the cath lab, which is on the second floor. The oxygen, now they are hunting around के oxygen लगाना है so that the patient can be transferred, because it's a part of their drill. When I say कि pulse oximeter में कितना sir 100% है, so then I said, why are you wasting time fussing for oxygenation when saturation is all right, when he's having severe pain? So you transfer him, we'll open his artery. So what I'm trying to say is, I'm not trying to say oxygen is not needed. What I'm trying to say is, don't fuss about oxygen. If it is there, it's a good add-on. But if it is not there, don't, try to delay a transfer to a cath lab center because इस वजह से रुका हुआ है. Coming to your second question of how should a patient be transferred? Ideally, he should be transferred in a cardiac care ambulance. You should have a basic, because these are patients who can suddenly arrest. They can have a ventricular tachycardia. But I want to re-emphasize and re-emphasize again and again that transfer is still the favored method as compared to keeping them in a primary or a secondary healthcare center where we will not be able to open the artery. So even if the risk of transfer, I won't remember the figures offhand, but I think the risk of transfer in the Parag trial, which was the largest ever trial, was 0.1%. And at that time when this trial was published, this was in, I think, 99 or 2000, that time they gave a figure of 6 hours. They said if the nearest cath lab center is within 6 hours, there is a 1 in 1000 chance that a patient will die. Therefore, transfer is still effective if you transfer, even if the cath lab center is 6 hours. I don't think in India, most of India now, there is a place where cath labs, unless you are in the very remote mountainous areas, I'm talking of plains, most of the plains will have a cath lab center within 1.5, 2 hours of the place where they have a myocardial infarction. Now, if that is the situation, I think transfer is still much more sensible than trying to, thrombolize and trying to, unless there is a contraindication or a patient has, severe financial issues and all that. Those are different subsets. I'm talking of, we are not getting finances into the whole thing.
What about transfer? Sometimes this cardiac, ambulance may not be available. Some people take private car, or can they be then transferred in ACLS?
They
Which
can
one
be
would be
transferred.
better?
These are all kind of logistic and social issues. Suppose you are in a place where an ambulance is going to reach in 2 hours time, whereas you have a personal car who can reach the cath lab center in 2 hours. I mean, we just take the chance and allow him to go. There's no point of keeping him there for 2 hours, then taking another 2 hours to be referred to a cath lab center. So you're wasting 4 hours.
I get that.
Yeah.
Sometimes, you don't, I've seen, in my experience personally, one of our doctor, maybe you also know, Dr. Gopal Sachdev, he died of a sudden cardiac arrest, perhaps because of MI. He chose to drive himself.
No, that is obviously not recommended.
Not
Yeah.
That is
recommended. Yeah,
obviously,
yeah, yeah.
yeah, that is
So,
obviously not
because
I
on
recommended.
the
must
way, he had,
intervene here. Our next speaker is here, but I must say, sir, it was such a pleasure listening to you talk about this in such a conversational tone. You simplified the entire thing, moved from anatomy to the physiology, electrophysiology of it. What is typical? What is atypical? What are the red flags? What should be the important touch points for treatment, what to look out for, and removing some of those myths. Oxygen transfer is safe up to 6 hours. So the role of the ambulance here, or the type of vehicle that is being used, is only for any contingency or route.
That's
And
right.
that's
That's
what
right.
you're preparing for. But
That's
don't
right.
keep waiting for it, waiting for the best vehicle. Move. The point is move as soon as possible. We'll hold
Absolutely.
on to you, sir, and any questions that come, we'll park them towards your side. I must now invite our next speaker, Dr. Sanjeev Bhoy. Welcome to the STG webinar, sir. Sorry, this topic took a little longer, but Dr. Bhoy and self, we go back to our AIMS days, long back, and it's such a pleasure to see you so active and leading the WHO Collaborating Center as well. And Trauma Center, of course, has come up beautifully. So we welcome you, Dr. Ranjit. Over to you.
Thank you, sir. Uh, Thank you, Dr. um, Madan sir, for such an informative session. Hope our all the participants will uh, use these informations during their clinical practices. Sir, now I request our next speaker, Dr. Sanjeev Boy sir.
Yeah. So thank you.
Just,
Doc-
just let me introduce our
Yes.
next speaker, Dr. Sanjeev Boyser, is a medical graduate from JSS Medical College with Mysore University, rank 1, and he is currently professor at Department of Emergency Medicine, JPN Apex Trauma Center, AIMS, New Delhi. He is also the director of WHO Collaborating Center for Emergency and Trauma in CR since 2000.
Rajiv, it's okay. I think we just brief. We can go direct.
Okay.
You know.
Okay, sir. Okay,
Thank
sir.
you. So kind of you for
Over to you, sir.
inviting me. That's all
Right.
right.
Okay.
So,
I think, yeah.
yeah. So first of all, I thank the esteemed panelists and NHSRC for providing this opportunity to share our thoughts to all our colleagues at the primary care, secondary care level facilities and tertiary care level facilities. Doctors, nurses, really a really opportunity to interact. So before I begin my presentation, I bring greetings from All India Institute of Medical Sciences, New Delhi, to all our esteemed panelists as well as colleagues. And uh, let me tell you, this is a very opportune moment to actually improve emergency and trauma services in this country. And the previous speaker was excellent, Dr. Madan, and he touched upon one other very time-sensitive condition, that is acute myocardial infarction. The other time-sensitive conditions which we look it at as stroke, and third is trauma. And these are the three important time-sensitive conditions besides sepsis. Unless you provide treatment early, then you will lose the life or their morbidity will be, huge. So with this, let me begin share my slides to so that everybody can have a look on this and we can start the lecture. Yeah. So Dr. Rajiv, can you see my slides?
Yes, we can see the slide. Yes. We can put it in slideshow now.
Yeah. I'll do that. Just a minute. Yeah. So today's topic is how do you really manage the time sensitive condition in a very timely manner so the patients' lives are saved, and how do you resuscitate them very well. So let me take you through the topic chosen today is basically mainly on resuscitation and of a safe transfer of the patients this thing. So let me take you to just to tell you a brief about the burden of emergency conditions in our country. The burden of emergency conditions, almost 40% of all conditions with emergency report to the emergency room or emergency department. And out of those, time-sensitive condition which I talked about is trauma, stroke, and STEMI. Beside that, you have snake bite, you have poisoning, you have mother and child emergency, respiratory conditions. Uh, so these are the top 10, 11 conditions which actually kills the patient. This is based on our study which we conducted, pre-COVID era, the AIMS Niti Aayog study. It was led by our department. And we found the top 11 conditions which kills the patients are really causing a lot of problems in our country. both in adult and pediatric. Out of this, 15 to 20% is actually trauma, the accidents. So 15 to 20%, both in pediatric and adults. It is of much importance because they are young people, they are young soul breadwinner of the family. And if they die, they lose a life, the whole family actually suffers. Even they survive, and you actually have polytrauma, so the disability is also huge. So they are unable to provide financial support to their family, and it also actually costs the whole the government by 3% of the GDP. Let me tell you a brief about what is the current status of death in our country due to trauma. In this year, it is 1.7 lakhs. And while we are speaking, every minute, 3.6 persons are dying in Indian road. That means every 4 person is dying in 1 minute. So by the time we finish 60, you can understand what will be the death we are talking about in our Indian roads. So this is the background. And how to, when they get injured, what is the normal journey of the patient? Let me just tell you. Suppose the person get I had an accident. So first thing the first thing is they bleed on the scene and they die. We have seen many patients that bleed on the scene and they die on the roads. Or when they're picked up by an ambulance, they may die en route due to again bleeding patients, bleeding. And once they reach the emergency department, actually the existing emergency room has got untrained, not adequately trained human resource. So when they reach there, they're unable to actually recognize, resuscitate, and timely refer the conditions to the definitive care, then the patient loses the life. So let us understand that how we can change the system. How we can really change the system is to create an emergency and trauma care system in this country. At the community level, at the pre-hospital care level, when they are going with the, I've not actually moved my slide. This is my initial first part. So timely en route in the ambulance. So we have to develop a good, robust ambulance pre-hospital care system. When they reach the emergency, you should have a adequately or highly skilled human resource, doctor, nurses, and paramedic to take care of the patients in the time critical period. So, and have a linked with a definitive care like surgeons, orthopedicians, surgeons who can timely, or medicine specialists who can timely take care of the patient. This is called as the emergency care system. So this is a system which has to be taken. To build this system, let us take a journey of a single patient. So this is early morning hours. A patient comes. You can see here, patient, most of the persons bring in Delhi, they are brought by the police people, not the CATS ambulance. CATS ambulance bring actually less than 5% of patients are coming by CATS ambulance. So police is also a responder here. Similarly, however, in our country, almost 20 states has got a good ambulance services, that is 108 service. Now it is 112. Universal number is 112. Few states have already adopted, such as Haryana, Punjab, and some other places. So once the patient, see early morning hours, a young gentleman comes to the emergency room with motor vehicle crash. He had an accident. Now on arrival, his BP is hypotensive, 80/64. He's tachycardic, he's tachypneic, cold, clammy, and confused. So how you will manage this patient? This is the everyday story we have. How do you manage this patient? So let us understand. So what we do is we do a primary survey of trauma. As per advanced trauma life support guidelines, this is called a primary survey and secondary survey. So we are focusing on the initial assessment and management. First thing you have to, in an emergency, first thing you have to do as soon as you receive a patient, what is called a triage. Is it that, what do you mean by triage? Is he sick or is he not sick? So that is what you see. You have to triage them as red, yellow, or green, just like traffic lights. We have red means is danger, right? Danger. Patient is in hypotension, tachycardia, tachypnea means physiology is disturbed. Unless you treat him, he will be killed in no time. From a condition which is called a yellow. In yellow, the vitals are stable. Okay, but he has got some fractures or a pain abdomen. He needs care. But you can delay a little bit of care to him. You can delay, you can attend him a bit later. This is very important where you need a district hospital or a community health center where the staff is less. So please, see if you have 3-4 patients, first see the red patient first, then the yellow. And third is the green. Green means those who are walking, wounded, minor injuries, or he has got some fever, a mild ailment. So you can see later. In your emergency, you may have lot number of patients coming together and you have limited staff. This is a usual story in everywhere. Okay, patient number will be more and staff will be less. So triage will help you to, differentiate which patient is to be attended first, then next, then next. And you can also explain the relatives about it. So this is the meaning of triage. So after you do triage, the patient you have taken him to the emergency room or emergency department, do your emergency. First thing is you have to stabilize his physiology. Like BP is low, so you have to address that. In this patient, tachycardia is there, you have to settle that. Patient is tachypneic, that means his lung is involved, right? He is cold, clammy and confused. That means his brain may be involved. Or due to hypoxia and hypotension, he may be altered sensorium. So you address that. That is called stabilizing the physiology. We'll talk one by one in detail. You have to use certain adjuncts like imaging to find out where the patient is bleeding from. This is a case of trauma. Where is the bleeding? Find out the bleeding, where is it bleeding? After you stabilize the physiology, then you will do a secondary survey. The meaning of secondary survey is look at the anatomical defect. Your concept is treat first, that kills first. Why it is so? And for doing that, you have to have a team. Like if you are a bigger hospital, you have many people around, doctors, nurses, paramedics, you form a team and give equal responsibility to each person. Even if it's a district hospital, limited number of people, or in community health center, you can still form a team. The team is not within the emergency, but the whole hospital people come from whole hospital. The different specialists can come from different parts of the hospital and form a team in the emergency. Because emergency will have less number of people anyway. But if you have a big tertiary care hospital, have this protocol. This is called as, and like you have a team leader. That is usually the consultant in the emergency or consultant senior person who is experienced person. He can be the team leader. The two things, EN1 and EN2, that means emergency nursing officer in the here and here. They stand here and here. The nursing, and then 3 young emergency physicians, 1, 2, and 3. Usually a medicine person here in the head end, medicine oblique anesthesia, right side a surgeon, and left side is the orthopedician. So they manage this trauma, and there are 2 hospital attendant 1 and 2. You can see that. The role and responsibility to manage this polytrauma patients, it can be done. So let me give you an example. What do you mean by this? At the handed. You know that while managing the patient, you require to manage the ABCs. Airway is managed usually by the person who is available there in the emergency. Or if not, you call the anesthetist. Or medicine person who is there, who knows how to intubate the patient. Okay, in the emergency physician 1, usually the surgeon who helps him to take care of the wounds, bleeding wounds, as well as can put a chest tube. Okay, and if the patient has got, say, broken bones, the orthopedicians are there. So if you have the luxury of all this, you can place them here. And there are 2, this nurse 1 helps in actually puts the IV cannula. On the right side, nurse 2 helps putting IV cannula here on the left side, right and left, and also take samples for grouping, cross matching, arranging the blood. And nurse 2 actually gives the drugs which is required for treating during the resuscitation part, including pain medication. There are hospital attendant 1 actually in a trauma patient, you need to expose the whole body to see where the patient is external bleed or not. Okay. And hospital attendant too actually helps the emergency physician to actually, when he is intubating, he helps in giving the ventilating tube and everything. Okay. So this is a formulation or formula, just like this is called what is called as horizontal resuscitation. Okay. When the patient comes, like you must have seen in Formula Car Race 1, how the car comes and immediately within some 5-6 seconds, within 5-6 seconds, the tire is changed and the car moves forward. Similarly, here, once you are in the emergency room, the immediately patient comes and do his job, airway, breathing, circulation, manage resuscitation, do the resuscitate in quick time. So, and have two protocols in place, which we call as code red, means follow the advanced trauma life support protocol, or the patient is arrested, cardiac arrest for the former code blue team, or code blue, which follow the advanced cardiac life support protocol. So this is an example of horizontal resuscitation. For example, you're in district hospital or community health center, you have one doctor, one nurse, and limited, hospital attendant with you. Then you start with first airway, then breathing, then circulation, and then disability. So we'll speak more in the subsequent slides. This is the enabling environment you need to create for resuscitating any patient who is critically ill and injured. First, have the, make the environment both patient friendly and performer friendly. That is very important. So this is our team, which is called a red area team, with the concept of treat first, that kills first. So how do you manage? So after you have created, that's why every emergency room should be rearranged. Okay. So we actually resuscitate this patient with the concept of 3R model. First is recognition. We have done triage in this case. Second is resuscitation. For resuscitating, you require to have an enabling environment in the emergency department and have protocols, processes in place and have a performance indicator. And if you are unable to, and also timely refer to the patient to different specialty. We'll talk about that. So when you do start managing this patient, so in bigger hospitals, you have cap, gown, gloves, mask, shoe covers and all that. But basic minimum gloves you should wear, and if you have gowns available in your hospital, you can use that. But please use at least mask, and gloves. And if you have other thing, luxury we don't have all this, but basic minimum thing, don't manage the patient with bare hand. For God's sake, because bleeding patient, you don't know how the patient has got, what is whether they have hepatitis B, C positive, we don't know, to protect yourself before protecting the patient. So in a concept of trauma, we use ATLS protocol. I'll also deal with what are the new changes also in the 2025 guidelines. So the concept of initial assessment and management of trauma and non-trauma victims are actually almost similar. You do a primary survey. That means stabilize the airway, breathing, circulation, disability, ABCDE, and use certain helping gadgets, such as, we'll talk about what are the helping that is called adjunct. That is imaging, ECG, leads, BP cuff, these are called as adjuncts. Okay. So the primary goal is to resuscitate, stabilize the patient. And if your patient does not improve, you again reevaluate the patient. Again, you go back to airway, breathing and circulation. Okay. So after you have done stabilize the patient, now the patient is for detailed secondary survey, means detailed evaluation from head to toe examination and front to back examination. You examine detail. Now you have time to detail. And whatever adjunct, suppose you require CT scans, further X-rays, like broken bones, swellings are there, you want specific skeletal X-ray, please do that. Okay, and again you reevaluate in the secondary survey and hand over the patient to definitive care. For example, patient has a blunt trauma abdomen. Okay, abdominal, there is signs of peritonitis. Please involve the surgeon early. General surgeon early for managing this case. Or if the patient is sick, recurring, say, suppose the patient has ABCs you have done and has a chest pain, you please involve the physician early, like Dr. Madan was saying. But the basic ED team should do the good, high quality resuscitation. This is actually lacking in most of the places. Okay. This is because if you see medicine, surgery, obs-gynae, pediatrics, these are the disciplines which is there since more than 100 to 200 years, well-established discipline. So what happens is when the patient comes, usually in the casualty, because there is lack of trained human resource, this is the area which has been neglected over the years. So the detailed golden hour or the platinum period golden hour is lost. That's why I'm emphasizing that train yourself hard in resuscitation. So let us see how do you assess the patient. Okay, what's a quick take? So how do you quickly assess a patient whether airway breathing circulation is fine or not? So what you can say, assessing in the patient in 10 seconds. So what we can do is you can tap the individual like this. Hey, how are you? Are you all right? And the patient कहता है कि सर मेरे को थोड़ा दर्द हो रहा है. That means एक तो बोल रहा है वो, so that means his airway is all right. Okay, his breathing is all right क्योंकि वो सांस से बोल रहा है, breathing all right. He is able to actually consciously आपको बता रहा है मेरे को दर्द हो रहा है. That means इनका ब्रेन का परफ्यूजन भी ठीक हो रहा है. That means circulation is all right. तो अगर मान लीजिए पेशेंट ठीक से कॉन्शियसली बोल लेता है, दैट मींस इन 10 सेकंड यू कैन बी एबीसीज आर ऑल राइट एट दैट पॉइंट ऑफ टाइम. ओके, सो what do you really mean by airway? What we do really? A means patent airway, B means sufficient air reserve to permit speech, जो मैं अभी कह रहा था आपको, and sufficient perfusion to actually for cerebration and clear sensorium. So the new guideline जो ABCD हम बातें करते थे for resuscitation in trauma, the previous edition जो था, it focused on airway, breathing, circulation, disability, and exposure environment. The new guideline says it is X ABCDE. What do you mean by this X? The X means there is exsanguinating hemorrhage. What is literally mean by exsanguinating hemorrhage का मतलब क्या है? Suppose there is arterial bleed. Arterial bleed जो होता है जब blood निकलता है फव्वारे की तरह निकलता है. फव्वारे pulsating, and it is suddenly patient can collapse. So from a venous ooze में थोड़ी देर bleeding होगा रुक जाएगा. That is not which will kill the patient. The arterial bleed spurters उससे डेथ हो सकती है. ये जो इसी को हम कहते हैं exsanguinating hemorrhage और catastrophic hemorrhage, कुछ भी नाम ले लीजिए, और dangerous hemorrhage. ये ज्यादातर देखा गया था इन मिलिट्री सेटिंग, व्हेन देयर कॉन्फ्लिक्ट वॉर, वहां पे ज्यादा क्योंकि गोलीबारी चलती है, नाइफ से चलती है, तो आर्टरी कटते हैं. आपने देखा होगा ये बहुत सारा. एंड सेम थिंग विच आल्सो किल्स इन द सिविलियन सेक्टर. तो इसीलिए उन्होंने कहा कि पहले आप ब्लीडिंग रोक लो अगर दिख रहा है तो. एंड साइमल्टेनियसली देन नेक्स्ट स्टेप इज यू हैव टू सी इज लुक फॉर ए फॉर एयरवे विद cervical spine restriction of movement. Okay, now cervical spine protection नहीं कहते, cervical spine motion restriction कहते हैं. अभी है तो वही, गर्दन को आपको हिलाना डुलाना नहीं है, सीधा ही रखना है. Number 2, B for breathing with adequate oxygenation. Okay, adequate oxygenation, like we'll talk in detail about it. C for circulation with control of hemorrhage. Way to address that. D for disability. यहाँ disability का मतलब है way to see, look for उसका level of consciousness. Disability यहाँ इसका मतलब नहीं है कि कोई fracture है. It is not, disability does not mean fracture in trauma. Okay. E for exposure. पूरा exposed body को करेंगे to look for any bleeding. ये आपको देखना है. And E for environment. Okay. Environment means patient कहीं hypothermic तो नहीं, blood loss हो रहा है. Blood loss, we know that we are all warm-blooded persons. The blood loss होता है even in hot summer, गर्मियों के महीने में भी patient hypothermic हो सकता है, especially trauma with blood loss. तो ये जो प्रोटोकॉल है XABCDE, especially trauma में, तो ये प्रायोरिटी चेंज नहीं होता है अगर आप इफ यू आर अ स्मॉल चाइल्ड और पीडियाट्रिक ट्रॉमा में, एल्डरली में या प्रेग्नेंट लेडी में, द प्रायोरिटीज विल नॉट चेंज, whether it is pediatric, geriatric or pregnancy. अब हम डिटेल एयरवे. वी हैड अ पेशेंट, हमारे पास ऐसे एक पेशेंट था, रोड ट्रैफिक क्रैश था, हेड एंड हेड कोलिशन हुआ था. आप देखिए पूरा फेस इसका स्मैश्ड हो गया है. तो आप देखेंगे हियर, आप मेरे को रेस्पॉन्ड करिए, क्या इसका एयरवे इसका कॉम्प्रोमाइज है? आप चैट बॉक्स में लिख सकते हो, इज हिज एयरवे इज कॉम्प्रोमाइज्ड? चैट बॉक्स में आप लिख सकते हैं मेरे. यस लुकमन, यस, वेरी गुड विनय. एक्चुअली क्या ना, देखिए मैक्सिलोफेशियल इंजरी है और पूरा फेस टूटा हुआ है इसका, तो दैट मीन एयरवे इज थ्रेटेंड. ये याद रखिए, क्योंकि मिड फेशियल इंजरी में पूरा एयरवे इसका लॉस है. ओके, तो आपको कैसे पता लगाना है कि एयरवे, आप जैसे मैंने कहा था, ट्रीट फर्स्ट दैट किल्स फर्स्ट. ये ABCD एल्गोरिथम हम इसे बनाया क्यों गया? बिकॉज अगर आप एयरवे अगर मैनेज नहीं करेंगे ब्रीदिंग से पहले, तो ए विल किल यू इन सेकेंड्स. टाइम नहीं लगाएगा, कुछ सेकेंड में ही कुछ सेकेंड में ही वो आपको किल कर देगा. So then if you don't manage B before C, अगर B breathing अगर मैनेज नहीं करेंगे सर्कुलेशन से पहले, तो breathing will kill you in minutes. And if you don't manage circulation before disability, it will kill you in minutes to hours. So that's why ये जो concept दिया गया है ABCDE, okay? Especially primary care के लिए ही बनाया गया है ये. चाहे वो CHC हो, PHC हो, कहीं पे भी आपको एक ही मंत्र याद रखना है, ABC ABC ABC. तो कैसे आपको पता लगाते हैं? आस्क द नेम. जैसे मैंने कहा है, कैसे हैं आप, क्या नाम है आपका, तो ये पहला सवाल पूछ सकते हैं. ओके, वो जवाब नहीं दे रहा है ना, मैं बोलूंगा कैसे उसको एसेस करना है. अगर बोल रहे सर मेरे को ठीक लग रहा है या मेरे को दर्द हो रहा है, इसका मतलब एयरवे इज ऑल राइट. सेकेंड मेथड जो है, लुक लिसन एंड फील. ओके, ये हम आप देखेंगे कि कैसे इसको एसेस करना है. ओके, तो आपने देखा होगा, है ना, लुक क्या देखना है. आपने देखा कि फेस में द फेस इज डिस्ट्रॉयड, इंजरी है, एयरवे थ्रेटन है. नंबर 2, ब्लड वॉमिट हो रहा है, ब्लड आ रहा है, तो दैट मीन एयरवे इसको थ्रेटेंड है. सेक्रेशंस हैं, वॉमिटिंग है. ओके, और मान लीजिए जैसे बर्न्स होता है, फेशियल बर्न्स है. फेशियल बर्न्स में क्या होता है कि एयरवे एडिमा भी होता है. बर्न्स में एयरवे एडिमा होता है, तो दैट उसमें आपको एयरवे लॉस हो सकता है. ओके, एंजियो एडिमा, जैसे एनाफिलैक्सिस होता है ना, कोई दवाई आपने लिया, एंजियोइडिमा लिया और आपका आवाज भारी होना शुरू हो गया, तो दैट मींस एंजियोइडिमा है, दैट मीन एयरवे थ्रेटेंड है. फॉरेन बॉडी, टंग फॉल, जैसे अनकॉन्शियस में आपने देखा होगा, हम कहते हैं इट इज थ्रेटेंड एयरवे, क्योंकि ये टंग पीछे फॉल हो जाता है एंड इट ब्लॉक्स द एयरवे को ब्लॉक कर देती है. ओके, तो दिस इज हाउ ऑन लुकिंग. एयरवे को देख के ही कैसे पहचान सकते हो कि एयरवे प्रॉब्लम हो सकती है. नंबर 2, यही हम कह रहे थे, देखिए. ओके, ये बर्न्स वाला पेशेंट है, ये नेक इंजरी, कभी का नेक स्वेलिंग है, बहुत हेड एंड नेक. फॉरेन बॉडी है बच्चे के मुंह में. टंग एडिमा, कभी का टंग एडिमा भी बहुत जबरदस्त हो जाती है एंजियो एडिमा में. इसमें आप इंट्यूबेट नहीं कर सकते, दिक्कत हो सकती है. लुक, ठीक है ना. लिसन, क्या सुनेंगे, पेशेंट जैसे आता है, अरे भाई कैसे हो, बोलेगा आपने सुना होगा ऐसे नॉइजी ब्रीदिंग करके, पेशेंट आंख बंद करके नॉइजी ब्रीदिंग करके आता है, दैट मीन्स आप जान लीजिए कि इसको एयरवे, हवा का ट्रैफिक में गड़बड़ी है. एयरवे नथिंग बट क्या है, हवा का ट्रैफिक, एयर वे. ठीक है ना. तो आप देखिए कि गर्गलिंग साउंड आएगा, होर्सनेस आएगा, ऐसे बोलेगा, अरे भाई क्या नाम है, डॉक्टर भोई है, तो यू सी हस्की वॉइस. तो ये भी आप चेंज इन वॉइस समझिए कि इसको एयरवे प्रॉब्लम है. और पेशेंट आता है स्ट्राइडर के साथ, स्ट्राइडर. तो जस्ट लुकिंग एट पेशेंट, उसको सुनिए, you can find the airway. Okay, and feel, जब आप फील करोगे, सॉरी about the slide थोड़ी इधर उधर हो रही है, तो आप फील करेंगे तो आपको क्रेपिटस मिलेगा. ओके, क्रेपिटस मतलब एयर लीक हो रहा है एयरवे से. तो इसी तरीके से आप पता लगा सकते हैं कि एयरवे थ्रेटेंड है या नहीं. कॉम्प्रोमाइज एयरवे मतलब साइनोसिस तो लेट साइन है जनाब. साइनोसिस इज द लेट साइन ऑफ एयरवे कॉम्प्रोमाइज. आपको वो नहीं देखना है, आपको पहला साइन देखना है. ओके, चेंज इन वॉइस, है ना, ट्राइडो, समझ गए ना, लुक, लिसन. अगर बोलेगा कैसे हो भैया, मैं ठीक हूं, या मेरे को दर्द हो रहा है, तो एयरवे फाइन है. आई थिंक यू आर अंडरस्टैंडिंग दैट सर. हमारा मेन काम है टू एस्टेब्लिश अ पेटेंट एयरवे. एयरवे हमें पेटेंट रखना है एंड प्रोटेक्ट द सर्वाइकल स्पाइन साइमल्टेनियसली. स्पेशली ट्रॉमा में, ट्रॉमा नहीं है तो सर्वाइकल स्पाइन की जरूरत नहीं है. तो व्हाट आर द मैन्यूवर्स वी डू. हम पोजीशन करेंगे कंफर्ट, हेड टिल्ट चिन लिफ्ट करेंगे मैन्यूवर, जॉ थ्रस्ट करेंगे, और सबसे इंपॉर्टेंट कि हमें सक्शनिंग, सक्शन apparatus होती है आपको, इमीडिएटली आप प्लीज सक्शन करिए. सेक्रेशन ऑफ ब्लड वॉमिटेज जो रहते हैं इमीडिएटली आपको निकालिए. ओके, दीज आर द सम ऑफ द इक्विपमेंट्स वी हैव, जो स्पेशली ट्रॉमा में हमें वाइड रिजिड सक्शन इसलिए यूज करते हैं. अगर आपके पास है तो यूज करिए. इससे क्या है, बड़ी इसके डायमीटर होती है, इमीडिएटली ब्लड और वॉमिटेज आराम से निकल जाती है. नहीं है तो जो आपके पास है उसी को प्लीज यूज करिए, लेकिन सक्शन करना जरूरी है. तो पहले थोड़ा 100% ऑक्सीजन दीजिए. जब भी सक्शन करेंगे 10 से 15 सेकेंड से ज्यादा आपको नहीं करनी है. पहले ऑक्सीजनेशन दीजिए, फिर आपको सक्शन करना है. So these are the some pearls of airway management. We are not going to speak about that. क्या क्या हम यूज कर सकते हैं, ये हमें ये यूज करना है कि इन्हें इमरजेंसी रूम और पीएचसी, सीएचसी, डिस्ट्रिक्ट हॉस्पिटल, यहाँ पे हम के इक्विपमेंट जो हमारे एटलीस्ट सक्शन अपैरेटस, ऑक्सीजन, बैग मास्क, ठीक है, कम से कम बेसिक चीजें हम रख लें. एक जो बेसिक चीज हम रख सकते हैं इन द इमरजेंसी रूम फॉर एयरवे मैनेजमेंट इज, है ना, कि एलएमए. देखो, इंट्यूबेशन जहां एनेस्थेटिस्ट है वहां कर लेंगे, ठीक है ना. बहुत जगह एनेस्थेटिस्ट बहुत बिजी भी रहते हैं, तो आप इमरजेंसी रूम में you please keep LMA, laryngeal mask airway, which anybody can put, even physician, nurses can also put a laryngeal mask airway, LMA, which is very easy to also learn. ठीक है ना. तो पहला आप क्या करेंगे, ऑक्सीजन दीजिए, बैक मास्क करिए, एंड अगर ऑक्सीजन आप कर पा रहे हो तो आप एसेस करिए भी कैसे एयरवे है, एंड इन्वॉल्व द एनेस्थेटिस्ट अर्ली इन दिस. एनेस्थेटिस्ट अर्ली फॉर इंट्यूबेशन अगर कर पा रहे हैं तो डिस्ट्रिक्ट हॉस्पिटल में एनेस्थेटिस्ट होते हैं, सीएचसी में भी होते हैं, प्लीज यूज देम एंड इंट्यूबेट द पेशेंट. इंट्यूबेट एयरवे प्रोटेक्शन करके ही आप हायर सेंटर भेजिए अगर आपका पेशेंट बहुत सिक है तो. अभी क्या होता है कि बहुत सारे पेशेंट हम डायरेक्टली भेज देते हैं, जाते जाते इंसान दम तोड़ देता है एम्बुलेंस में, या हॉस्पिटल पहुंच टर्शियरी केयर लेवल आने से प्रॉब्लम होती है. तो हमें अगर प्राइमरी केयर दुरुस्त कर दें, सेकेंडरी केयर में जिसका बेसिक मिनिमम एयरवे करके हम भेज दें. देखिए, ये एयरवे प्रॉब्लम करना बहुत इंपॉर्टेंट है. इवन स्नेक बाइट में हमने देखा है कि कोबरा एंड क्रेट बाइट में सबसे मेन प्रॉब्लम होती है रेस्पिरेटरी अरेस्ट का. पेशेंट डाइज ड्यू टू रेस्पिरेटरी अरेस्ट. तो अगर मान लीजिए हम प्राइमरी केयर में एटलीस्ट एलएमए डाल के 108 में बिठा के हायर सेंटर भेज दें, एंटी स्नेक वेनम दे के, तो पेशेंट बच सकती है. तो दीज आर द बेसिक थिंग्स वी कैन डू. एंड अगर जहां लगा आपको, जो मैंने वीडियो दिखाया, दैट इज अ पूरा फेस टूटा हुआ, इंट्यूबेशन तो आप कर ही नहीं सकते उसमें. तो उसमें हमें क्या करना है, सर्जिकल एयरवे करना है. मेरे नेक में एक छोटा सा होल करना है, दैट इज कॉल्ड सर्जिकल क्रिकोथायरेटमी. सर्जिकल क्रिकोथायरेटमी कौन कर सकते हैं, वहां पे आपके पास सर्जन्स हैं. सर्जन्स को आप बुलाइए इमरजेंसी में, एंड ही कैन डू अ सर्जिकल एयरवे, क्रिएट अ सर्जिकल एयरवे. ये सब लाइफ सेविंग प्रोसीजर है, ये बहुत लाइफ सेविंग है. तो फर्स्ट चेन ऑफ सर्वाइवल हमारा एयरवे होता है. ओके, इसके बिना, सो जैसे मैंने कहा, ट्रीट फर्स्ट दैट किल्स फर्स्ट. अब हम आते हैं कि कभी कभी क्या होता है कि एयरवे आपने मैनेज किया एंड आपने लगा दिया भाई, वेंटिलेटर पे भी लगा दिया, ठीक है ना. कभी कभी इक्विपमेंट फेलियर से भी प्रॉब्लम हो सकती है. अगर मानो इंट्यूबेशन के बाद भी आपका सैचुरेशन इंप्रूव नहीं करता है, तो आप क्या सोचोगे, है ना. या तो इंटरवेंशन आप देखिए एक निमोनिक वे है जिसे हम कहते हैं डोंट बी अ डो. ओके, डिसलॉजमेंट ऑफ ट्यूब, ऑब्स्ट्रक्शन ऑफ ट्यूब, पेशेंट को निमोथोरैक्स हो गया है, ओके, या इक्विपमेंट फेलियर है, तो ये आपको इमीडिएटली एड्रेस करना पड़ेगा. और मेन कॉन्सेप्ट है कि एयरवे के साथ सी स्पाइन आपको मतलब सिर को हिलाना डुलाना नहीं है, सीधा रखना है और आपको प्रोटेक्ट करना है सर्वाइकल स्पाइन को. कभी कभी चोट से पैरालिसिस हो सकती है. तो आफ्टर वी स्टेबलाइज द एयरवे हम जाते हैं ब्रीदिंग पे. ओके, इन ब्रीदिंग ये टू कैसे ब्रीदिंग एसेस करेंगे, एसेस हम एसेस करेंगे, रेस्पिरेटरी रेट देखेंगे, chest movement we'll see, we'll look at the air entry, both auscultate will do, and look at the air entry, is it equal or there is absent breath sound on one side. And oxygen saturation, हमारा गोल क्या है ब्रीदिंग में ट्रॉमा में, टू फाइंड आउट कि भाई क्या इसको does he have a tension pneumothorax, okay, which can kill him immediately, or a massive pneumothorax, or a open sucking wound, means open chest wound, टैप कर दिया तो देयर इज ओपन सकिंग वुंड. हमारा प्राइमरी गोल प्राइमरी सर्वे में क्या होता है, लाइफ थ्रेटनिंग इंजरीज पकड़ना एंड एड्रेस देम. ओके, so this is what we are talking, fast breathing, neck vein distended, chest movement asymmetry and cyanosis, right. Let it look, हम देखेंगे. और what we'll listen means I can't breathe, he बोलेगा कि जब ऑस्कल्टेट करेंगे तो आपको या तो नॉइजी ब्रीदिंग लगेगा या एब्सेंट ब्रेथ साउंड लगेगा. एब्सेंट ब्रेथ साउंड और डिक्रीज ब्रेथ साउंड किसमें मिलता है हमें, we'll get in pneumothorax or hemothorax, right. Okay, so this is our look, listen and feel. So how do you manage breathing? Remember हम हमारा टारगेट क्या है कि we to keep the SpO2 more than 94% and assist ventilation if required. The various devices for oxygen therapy जो available है for critically ill and injured patient are nasal prong, facial mask, non-rebreathing mask and nebulization mask. Okay, so face mask तो सब जगह I think मिल जाता है, right from community health center to medical college. Okay, but delivery of oxygen is not that, it is only 60% RTN. If you have non-rebreathing mask, it has got a delivery up to 95%. The best is non-rebreathing mask. Suppose you have developed, a patient has developed a tension pneumothorax. Tension pneumothorax, how do we diagnose? There will be a patient will have, diminished chest movement on the affected side. When you auscultate, there will be absent breath sound. जब आप percuss करेंगे, it will be hyper resonant note. Saturation will be low, BP will be low. So this and neck veins will be engorged, and there will be mediastinal deviation of the trachea to the opposite side. Suppose there is right side tension pneumo, it will shift to the opposite side. So immediately what you have to do is you have to do a needle decompression. Okay, remove the tension physiology. Tension निकालिए. So you put in a needle in the fifth intercostal space. Okay, and आजकल guidelines आगे even second you can put. So fifth intercostal space in the area of safety. So at the mid axillary line. So mid axillary line you have to put the, put the needle there. Okay, so you have to put the needle here of length of more than 5 centimeter. Needle आप डालिए और gush of air जैसे आ जाएगा. Then after that you convert that needle thoracostomy to putting a intercostal drainage tube. 32 French का आप डालिए, 28 to 32 French आप डाल सकते हो. Recent guideline कहते हैं 14 भी डाल सकते हैं. But 14 most of the emergency departments में rooms में होते नहीं हैं. 28 to 32 मिल जाता है मेरे को. And if you are not trained, please call the surgeon, he will put. So this is a skill everybody can learn. Nowadays, as per it is, primary care physicians, around say you can use this, learn this technique and save a lot of lives. Needle and tube. ज्यादा हम बड़ी बड़ी बातें नहीं कर रहे हैं, हम नीडल और ट्यूब की बातें कर रहे हैं. जैसे एयरवे हमने बात किया, एलएमए देंगे, ऑक्सीजन थेरेपी है, ऑक्सीजन हमारे पास है. We have, if you don't have LMA, please procure LMA. ओरोफेरेंजियल एयरवे आप यूज करिए, गुडल्स एयरवे, वाई सिंपल हम करेंगे, टिल चिन लिफ्ट और जॉथस इन ट्रॉमा. मुंह खोल के आप ओरोफेरेंजियल एयरवे भी डाल देंगे तो टंग फॉल नहीं होएगा. इट इज वेरी सिंपल. In breathing, oxygenation, both airway breathing and oxygen is the main treatment, or needle tracheostomy and putting a chest tube. Okay, that is how you manage breathing, right? तो आफ्टर वे और एक करने के बाद ही आप दूसरा जाएंगे, ऐसे नहीं कि ए और बी, ए के बाद फट से दौड़ गए आप बी में. तो आप पहले ए को सिक्योर करेंगे क्योंकि आपके लिमिटेड स्टाफ है, डॉक्टर नर्स पैरामेडिक हैं. ए को सिक्योर किया, फिर आप ब्रीदिंग में जाइए. गो टू द ब्रीदिंग. आफ्टर यू हैव सिक्योर्ड ब्रीदिंग, जब आप बी एसेस करके इतना कर लिए, आप रेडियोग्राफर को बोलिए कि कॉल दीजिए, कॉल द रेडियोग्राफर टू डू अ एक्सरे. बेड साइड एक्सरे आपके पास है तो बुला लीजिए, नहीं तो सब कुछ कराने के बाद ही आप एक्सरे रूम को भेज सकते हो अगर पेशेंट स्टेबल है तो. सो अगर नाउ यू हैव डन एयरवे ब्रीदिंग, नाउ लेट्स लुक फॉर सर्कुलेशन. दिस इज द मोस्ट इंपॉर्टेंट किलर इन ट्रॉमा पेशेंट और एनी नॉन ट्रॉमा पेशेंट. शॉक मैनेजमेंट. इवन आपने देखा होगा एक्टॉपिक रप्चर्ड एक्टॉपिक प्रेगनेंसी, दे डाई ड्यू टू ब्लीड. Postpartum hemorrhage, they die due to bleed. Upper GI bleed, they die due to bleed. Lower GI bleed, they die due to bleed. The hemoptysis, they die due to bleed. So, shock management is common for both trauma and non-trauma. So, trauma के हम थोड़ा index case लेते हैं, देखते हैं. So, what will happen to the patient? Patient will have altered sensorium. क्योंकि BP गिर गई है तो brain में perfusion कम है, and patient may have altered sensorium. गफलत में होगा वो. You know, you'll have cold clammy skin. याद करिए जो पेशेंट हमने लिया था, cold clammy skin, skin color pale होगा, you know, cold हो जाएगा, pulsate tachycardic and feeble pulse, and urine output will be low. Okay, urine output will be low. ये है आपके ब्लीडिंग के when you say patient is in shock, क्या मेरे पेशेंट शॉक में है, आपको ये देखना पड़ेगा. जब आप देख रहे हो पल्स बीपी से तो नहीं होता, आपको ये भी देखना है कि भाई ब्लीडिंग कहाँ से हो रही है. Where is the bleeding? You have to also find the source of bleeding, है ना? Very important. तभी तो आप रोकेंगे ब्लीडिंग को. So blood in the एक famous dictum है, ये याद कर लीजिए one liner. Blood in the floor, look for 5 more. So what is this statement? इसका मतलब क्या है? हम आगे जानेंगे. Blood in the floor, look for 5 more. Blood on the floor मतलब बाहरी ब्लीडिंग हो रहा है, स्कैल्प में हो रहा है, बाहर कट गया, तो यू हैव डन, सारा जगह ब्लड हो गया. तो आप 4 जगह और देखेंगे. चेस्ट में ब्लीडिंग हो रही है, हीमोथोरैक्स है क्या? एब्डोमेन में है क्या? हीमोपेरिटोनियम है क्या? ओके, एंड ओके, एब्डोमेन में ब्लीड होंगे तो क्या ये डज ही हैव हीमोपेरिटोनियम? इधर पेल्विक बोन फ्रैक्चर्ड, इधर ये लॉन्ग बोन इंजरी और मैक्सिलोफेशियल इंजरी. दीज आर 5 प्लेसेस जिसे हम कहते हैं ब्लड ऑन द फ्लोर, लुक फॉर 5 मोर. When we have, जब हम सर्च कर रहे हैं, these are bleeders, okay? The basic principle is to control the hemorrhage, restore the volume, blood loss हो रहा है, replace blood, and reassess the patient. क्या मेरा patient ठीक हुआ, improve किया? You have to keep on reassessing, or patient did not improve. Okay? So it is very important to understand that. Most of the time, I have seen my residents, you know, they are very after the pulse, blood pressure, respiratory rate, saturation, capillary refill time. हम करते नहीं कभी, capillary refill का करिए, है ना? So you can see finger, this is pale, you just compress here, compress करिए आप बोलिए capillary refill and छोड़ दीजिए. So this जो pale हो गया था, suddenly it should become pink, okay? Pink. So if it is more than 2 seconds,
Ranjit, I think we have lost Dr. Sanjit.
Sir, you are not audible.
I think he lost his connection.
Hello.
आप कॉल कर लो एक बार.
Okay.
डॉक्टर रंजीत फोन कर लो उनको.
Okay, sir. Okay, okay, sir. There is some problem in his computer. He is restarting his computer. So just wait for some time.
Okay. I think the while he's joining, the very important message that he's emphasizing again and again is that ABC is very very important. Securing airway is the most important step. And even if you see a patient in shock, many people reply by saying, "We'll put a IV line first." But the fact is that we need to secure a airway, start oxygen, then go for IV access and other treatment. So that is the take home message. Prioritization is very important, because many times we know the right treatment, shock, you give the right fluid, right bolus, but if it is not given in a proper sequence, if oxygen is not started, then it will cause more harm to the patient. So airway starting with oxygen is very important. Dr. Madan, yes, in the previous session, one more thing that I would like to add is, once the patient is I think he's joining. Hello, I hope you can hear me.
Yes, ma'am. You are audible.
Have you put the post test in the chat box? No.
No, no, madam. We need.
Somebody is saying post test done. We hadn't posted that yet. Anyway, one more take home message for all emergencies, including the STEMI elevation, acute coronary syndrome patient. Documentation, proper referral letter is very, very important. One must, document the time of the incident, when this happened, symptoms, what was the time of the first medical contact, when was ECG was done, what were findings, whether aspirin or clopidogrel was given or not, anticoagulant given or thrombolysis, if thrombolysis was done at the peripheral level, if done, what was the time, did you look for the contraindications, vital signs, risk status, and reason for referral. All this should be very well documented, well, when you are referring these patients, because this poor documentation can lead to treatment errors. Similarly, we do, upward referral is done very often and correctly, but reverse referral or follow up of these patients when they are back in their home for secondary prevention is also equally important. Acute phase we do give importance, and once the patient is discharged, many patients stop medicines and they do not attend follow-ups. So it is very important for all of us to emphasize this repeatedly, that they need to continue these antiplatelets, statins, beta blockers, or whatever ACE inhibitors were started. They need to continue these. So, and of course, the lifestyle counseling about smoking, diet, physical activity, these are all very important, because otherwise the patient will keep having repeat attacks. Cardiac rehabilitation, diabetes, hypertension, and lipid control, and recurrent symptoms if they are. So always get the consultant's second opinion about this, and do consider cost of long-term medicines in acute settings. When it is a question of life saving, many people don't mind the even if these medicines are costly, but once these are started and they need to continue this lifelong, do consider cost and ask them upfront that whether it is okay with them. Many of them may not admit in front of you, but quietly will stop taking these medicines. So, therefore, the complete package, and those at peripheral level, primary prevention, health promotion is equally important. Ending up in a STEMI is not a good, we have to spend so much on diagnosis, treatment, rehabilitation of these patients, but whereas these could be simply, prevented by adopting a healthy lifestyle. But if the patient is already having diabetes, hypertension, we need to emphasize on the control of both these conditions. Has
Hmm.
he joined?
Yeah,
Yes.
I think
Okay,
Dr.
okay.
Sanjeev is back. Yeah.
Yeah, so,
Okay.
okay.
We can
Carry
continue
on,
now. Yeah.
please. Yeah.
So thank you, Sangeeta madam, for bailing me out, my in between my computer.
Eh,
Dhanyavad.
no, you're welcome.
So thank you very much, madam. I was speaking that the main way of finding out if the patient is my patient is in shock is patient will have hypotension, patient will have tachycardia. The most important aspect. Third is capillary refill time. If it is more than three or more than 3 seconds, it is again in shock. Patient may be in altered sensorium. It so any patient coming with shock and altered sensorium, please do not attribute straight away that it is a head injury. It can be due to both hypoxia and hypotension. Like I said, A, B, C. It can be a B problem, A problem, or C problem. Right? First, you attribute that, and you start resuscitating. Remember that. The most important out of all these parameters, the most important parameter in my patient is in shock is urine output. Patient is oliguric, less than 0.5 ml per kg per hour. For example, a 50 kg man, if it is less than 25 ml per hour, उसका urine आ रहा है, that means the patient is in shock. Remember this, the most hard sign. So now we know the patient shock में है. We have to find out the bleeder. I told you the famous dictum, blood in the floor, look for 5 more. तो कैसे हमें सर्च करना है? One is obvious bleeding, obvious फ्लोर में ब्लड पड़ा होगा, or there is a arterial bleeding, or you have to search the bleeding in the chest, abdomen, pelvic and long bone. How to do that? So let us understand. We can ask, in the meantime, we can, after we stabilize the patient, अगर आप portable X-ray है, तो you can order a chest X-ray and pelvic X-ray. If not, after you stabilize the patient, then you can send him. Remember that unstable patient should not go to the radiology because the patient get killed in the radiology department. They're unstable. Suddenly they will arrest. So you can see here, this is the chest X-ray of that patient whom we are talking about the clinical scenario जो हमने लिया था. You can see you have to read the chest X-ray in the ABCD format. A for airway, airway central. B for breathing. आप देखिए, B for breathing from, you have to see from periphery to center, center to periphery. तो आप क्या देखेंगे? Costophrenic angle, cardiophrenic angle. Right side and left side. Right side it is visible. So look for any evidence of pneumothorax or hemothorax. There are two things we have to see in chest X-ray, which you have to do immediately. You can manage in the emergency room. Okay. So here and right side is visible, left side is not visible. Both cardiophrenic and costophrenic angles are not visible. That means there is a hemothorax here. Similarly, this is the one maybe the cause of hypotension. Okay, in this patient. Secondly, this is a pelvic X-ray. You can see here the three things we see in pelvic X-ray is it's a bigger rounded structure, a circle we see here, 3 circles we need to see, bigger one and 2 small circles. You see that? So you can see in between is the pubic symphysis. So in this pelvic fracture, there is a widened pubic symphysis. This is a suggestive of a open book fracture of the pelvis. This itself causes torrential hemorrhage. The patient, the whole blood volume can be accumulated in this big large circle. ये समझ रहे हैं ना, पूरा एकदम accumulate हो जाता है. And the whole patient will, सबसे commonest cause of death जो सीन में होता है accident patient में pelvic fracture के वजह से. So If we are timely, we are able to recognize them. एक्सरे नहीं करने से भी अगर आप पेल्विक कंप्रेशन टेस्ट करके देखेंगे, आपको पेल्विक कंप्रेशन बिल्कुल लूज मिलेगा पेल्विस, जो आप लैटरली एंटीरियर सुपीरियर इलियक स्पाइन पे अपना हाथ रखिए and extend it like this. So if you are able to, normally you will not be able to open it. Normally आप करके देखिएगा, so it will not be able to open. But in case of pelvic trauma, easily you will be able to open it. So open book की तरह अगर आप open कर पा रहे हैं, that means this is the cause of shock. And immediately you can manage them. Okay, so I'll tell you, this is the biggest killer and way to, the biggest killer in trauma is hemorrhage. जिसमें हम कुछ कर सकते हैं as emergency doctors or primary care physicians, and wherever the patient comes, we should be able to do that. Dusra, if you have ultrasound machine in your hospital, in the emergency or in the radiology, nearby radiology, you can do a extended fast. Extended fast means focus assessment abdominal sonography in trauma. Extended means आपको bleeder ढूंढना है दो जगह, एक तो chest में, okay, hemothorax, and second is hemoperitoneum in the abdomen. And also you have to pick up pneumothorax by ultrasound. You can also pick pneumothorax by ultrasound. पुराने जमाने में हम कहते हैं कि you cannot ultrasound में air pick नहीं कर सकते. But science has changed full circle. In 2005, Daniel Lichtenstein बोल के एक जनाब थे, उन्होंने अल्ट्रासाउंड से एयर pneumothorax देखने का उन्होंने आविष्कार किया. तो आप, and it is a better test than the X-ray. अगर आपका एक्सरे यूनिट बहुत जगह क्या होता है, 2 बजे के बाद रेडियोग्राफर नहीं होता है ना. आई नो दिस बिकॉज हम एक नेशनल एक स्टडी भी कर रहे हैं, द डिस्ट्रिक्ट हॉस्पिटल लेवल, पीएचसी लेवल, सीएचसी लेवल. वी आर वर्किंग ऑन 57 डिस्ट्रिक्ट हॉस्पिटल, प्राइमरी एंड सेकेंडरी केयर हॉस्पिटल्स इन द कंट्री करेंटली टू इम्प्रूव इमरजेंसी और ट्रॉमा में हम काम कर रहे हैं. 3 प्लेसेस वी आर वर्किंग. आई एम टेलिंग यू दिस रियलिटी. तो बट वहां पे मैंने देखा है कि अल्ट्रासाउंड मशीन मिल जाती है बिकॉज ऑफ एमसीएच प्रोग्राम. So you can send them and use them and you can do them. Fix this. This is life saving. Air and fluid in the abdomen. Surgeon आपके पास है, anesthetist आपके पास है ना. So this is another way of gynecologist हैं. So pick up the fluid there. Okay. So this is one. So I was telling you about the district, this 57 hospitals we are working. 3 places we are working. One province in Arunachal Pradesh, one province in Gaya, इन बिहार, 1 डिस्ट्रिक्ट काम कर रहे हैं, जहाँ सब सेंटर से लेके मेडिकल कॉलेज तक हब एंड स्पोक मॉडल में कर रहे हैं टू इम्प्रूव इमरजेंसी एंड ट्रॉमा सर्विसेज. एंड अयोध्या. सो वी आल्सो अंडरस्टैंड द ग्राउंड रियलिटीज क्या है हमारा. तो हमें इमीडिएटली व्हाट वी हैव टू डू इज, जो भी आईवी कैनुला आपके पास है, आइडियली तो ग्रे में हम ग्रे कैनुला, 2 आईवी कैनुला हम बोथ एंटी क्यूवेटल वेन में लगाना है. जनरली हम क्या करते हैं कि we put the IV line in the periphery, यहाँ पे लगाते हैं. So patient अगर शॉक में है तो ये वेन्स जो आपके बिल्कुल वेसो कंस्ट्रिक्शन हो जाएगा, मिलेगा नहीं. आप कोल्ड क्लाइमेट स्किन ऑलरेडी है, तो आपको एंटी क्यूवेटल फोसा में दोनों में वाइड बोर जो भी अवेलेबल है, आइडियली तो हम कहते हैं कि ग्रे, बाकी जो भी अवेलेबल आपके पास है यहाँ पे लगाइए, ना कि यहाँ पे, बोथ इन कार्डियक अरेस्ट और हाइपोटेंशन शॉक. गिव IV fluids. Ringer lactate is the fluid of choice in trauma, okay, or normus line, whichever you have, okay, but don't give colloids. Himaxil वगैरह नहीं देना है. No himaxil और वो नहीं देना है, उससे coagulopathy हो जाती है. So please give RL or normus line. How much to give? Okay, earlier हम तो कहते थे it is 1 liter, 20 ml per kg, okay, क्योंकि आजकल नया जो गाइडलाइन आ गया है, ये 1 साल पुरानी गाइडलाइन थी जो मैंने लिखा है इधर. अगर आपके पास ब्लड बैंक है, ब्लड बैंक आपके हॉस्पिटल्स में है, जानता हूँ डिस्ट्रिक्ट हॉस्पिटल में है, मेडिकल कॉलेज में तो होता ही है, बट डिस्ट्रिक्ट हॉस्पिटल में कई जगह राउंड द क्लॉक नहीं है, 2 बजे के बाद फंक्शनैलिटी इश्यूज है, मुझे पता है ये. तो अगर आपके पास ब्लड है तो जल्दी ब्लड देने बेसिकली. तो अगर जल्दी अगर अवेलेबल है तो इवन नाउ लेटेस्ट गाइडलाइन कहती हैं कि 250 to 500 ml ऑफ रिंगर लैक्टेट आप दे सकते हैं, उसके बाद जल्दी से ब्लड या ब्लड प्रोडक्ट दीजिए. अगर नहीं है तो यू कैन स्टिल गिव 1 liter ऑफ रिंगर लैक्टेट और नॉर्मस लाइन, 1 to 2 liters, और तब आप देखेंगे पेशेंट का रेस्पॉन्स देखिएगा. तो लेट अस सी कैसे करना है. अब जब आपने फ्लूइड और तो दे दिया आपने, अब नाउ यू हैव टू सी हाउ द पेशेंट इज रेस्पॉन्डिंग इन शॉक. Either, if the patient is at three categories: rapid response, transient response, and minimal or no response, right? Rapid response में हमने fluid दिया, blood दिया, immediately pulse, tachycardia settle हो रहा है, BP ऊपर जा रहा है, urine output improve हो रहा है, okay? So in this, okay, remember the need for blood is very low, right? You can still you can give grouping, cross matching करके आप आराम से ब्लड अगर देना है तो दीजिएगा. मेनली उसको ऑपरेशन के टाइम में आपको जरूरत पड़ेगा रैपिड रिस्पॉन्डर. दूसरा आएगा, आप लीजिए कि ट्रांजिएंट रिस्पॉन्ड. यहाँ पे ये भी कर सकते हो, पेशेंट रैपिड रिस्पॉन्ड कर गया, अगर आप CHC में हैं तो यू कैन सेंड हिम टू द हायर सेंटर, जहाँ पे सर्जन है, जहाँ एडिक्वेट फैसिलिटी है, रिस्पॉन्डर है, इतना करके टाइमली रेफर भी कर सकते हो आप. तो इमीडिएटली पेशेंट को तो सब में जो शॉक में आया, आप इमरजेंसी स्टेबिलाइज करिए. दैट इज द मेन थिंग. विदाउट स्टेबिलाइजिंग प्लीज डोंट सेंड, ही विल डाई इन द एम्बुलेंस इटसेल्फ. ओके. दूसरा है ट्रांजिएंट रिस्पॉन्ड. थोड़ा आपने दिया, फ्लूइड दिया, रिस्पॉन्ड नहीं किया, बीपी थोड़ी देर के इंप्रूव हुआ, फिर दोबारा नीचे बीपी स्टार्टेड फॉलिंग एंड देयर इज टैकीकार्डिया. इसमें क्या करने का, अर्ली ब्लड देने का. इन्वॉल्व द सर्जन अर्ली एंड लेट हिम टेक फॉर लेप्रोटमी. ओके. थर्ड इज, आपने ब्लड फ्लूइड दिया, रेस्पॉन्ड ही नहीं किया, तो इसीलिए आपको इमीडिएटली सर्जन को अर्ली केयर में बुलाना है एंड ही हैज टू टेक ए डिसीजन टू टेक द फॉर लेप्रोटमी और नॉट. ये साल्वेजेबल पेशेंट है. व्हाई आई एम सेइंग इन डिस्ट्रिक्ट हॉस्पिटल, बिकॉज डिस्ट्रिक्ट हॉस्पिटल का हैज OT, it has got anesthetist, it has got surgeon. Immediately, laparotomy करके, immediately they can do damage control surgery और patient को, they can save the life. उसके बाद मान लीजिए अगर उसका फर्दर केयर करना है, ICU केयर चाहिए, after they do damage, they can send to the higher facility. So the main goal of circulation is stop the bleed. कहीं पे भी ब्लीडिंग हो रहा है, ब्लड टैप खुला हुआ है, ब्लीडिंग हो रहा है. द फेमस सेइंग मेरे टीचर ने बताया था, द ब्लड टैप इज ओपन. व्हाट इज द ट्रीटमेंट ऑफ ब्लीडिंग? IV फ्लूइड नहीं है या ब्लड नहीं है, वो तो टेम्परेरी है. क्लोज द टैप. टैप को बंद करिए. पानी, नल का खुलता है ना, पानी बहता रहता है, टंकी खाली हो जाती है. तो जब तक आप नल का बंद नहीं करेंगे, टंकी खाली कहाँ से? जितना टंकी में पानी भरते रहेंगे, अगर नल का खुला है तो नीचे चला जाएगा. बॉडी एक टंकी की तरह है ना हमारा बॉडी. तो आपको ब्लड टैप इज ओपन, क्लोज द टैप. इनिशियली व्हाट वी कैन डू, फ्लूइड, ब्लड, इन्वॉल्व द सर्जन. अच्छा, क्या क्या मेथड्स कर सकते हैं जो इमरजेंसी में आराम से, सिंपल मेथड्स हम कर सकते हैं एंड वी कैन सेव द लाइफ. दिस इज ट्रू फॉर ट्रॉमा का एग्जांपल दे रहा हूं, बट इट इज डन फॉर आल्सो नॉन ट्रॉमा. ओके. सो जैसे कि ट्रॉमा मैंने बोला कि डायरेक्ट प्रेशर आप दीजिए. ओके. तो इफ इट स्टॉप्स, वेरी गुड. लाइक स्कैल्प, आई हैव सीन स्कैल्प ब्लीडिंग में बहुत सारे शॉक में आते हैं, डायरेक्ट प्रेशर. ओके. देन प्रेशर बैंडेज बांध दिए. टूर्निके, वेरी इंपॉर्टेंट. टूर्निके आपको बांधना आना चाहिए. यू शुड नो हाउ टू टाई अ टूर्निके बाय यूजिंग द existing. We'll show you some pictures in the subsequent slide में दिखाता हूँ उसका मेथड. थर्ड, स्प्लिंटिंग. अगर फ्रैक्चर्ड लिम्ब है, फ्रैक्चर फीमर, almost 750 ml of blood is lost in fracture femur. 750 लॉस होता है, 750 से 1.5 लीटर तक लॉस हो जाता है. पेल्विक फ्रैक्चर में कितना लॉस होता है? ऑलमोस्ट 5 लीटर्स. कैन यू इमेजिन? 5 लीटर्स. अगर मान लो 70 किलो का इंसान है तो ब्लड वॉल्यूम कितना होता है एक इंसान में? 70 ml पर kg, है ना. मेरा जैसे 70 मेरा है वेट, तो मेरा ब्लड वॉल्यूम होगा अराउंड 4.9 लीटर. 50 kg का आदमी का होगा अराउंड 3.5 लीटर. समझ रहे हैं? सो पूरा ब्लड वॉल्यूम हमारा पेल्विस में फ्रैक्चर में बह सकता है. तो हाउ टू स्टॉप दैट ब्लीडिंग? यूज ए पेल्विक बाइंडर, रिड्यूस द पेल्विक वॉल्यूम. उसमें अभी हम सब्सिक्वेंट स्लाइड में मैं आपको दिखाऊंगा. थर्ड इज डैमेज कंट्रोल सर्जरी, इन्वॉल्वमेंट ऑफ सर्जन अर्ली, जिसे मैंने कहा बहुत इंपॉर्टेंट. उनको भी क्या काम करना है? पेट खोल के क्या करना है? ऑर्गन नहीं निकालने. उनको जहां ब्लीडर हो रहा है उसको डायरेक्ट प्रेशर देके रोकें और पैकिंग करके. बीपी, उनका मेन गोल क्या है? बीपी ठीक करना. बीपी ठीक करना है, एसिडोसिस ठीक करना है, कोगुलेशन ठीक करना है. उसके बाद दोबारा से पेट सिलाई करके बाहर आ जाए. ओके, इमीडिएटली. तो उसके बाद फिर 72 आवर्स के बाद फिर आप डेफिनेटिव सर्जरी करेंगे ऑर्गन इंजरी के बाद। वो हमारा काम नहीं, ऑर्गन का करना। अब हम आते हैं कंट्रोल ब्लीडिंग, हाउ वी डू दैट। डायरेक्ट प्रेशर, वुंड पैकिंग हमें करनी है, टूनिकेट, स्प्लिंटिंग एंड पेल्विक बाइंडर। टेक वन बाय वन, ठीक है। डायरेक्ट प्रेशर, सॉरी, या डायरेक्ट प्रेशर, ओके। टूनिके, ये देखिए, टूनिके वुंड से पहले अराउंड 5 सेंटीमीटर अबव द वुंड ये टू डू अ टूनिके, यू नो। आप अपना एक गॉस पीस लीजिए, वो वाला। डोंट यूज पोलिस कैथेटर, यू नो, पोलिस कैथेटर, वायर, ये सब यूज नहीं करना है, ओके। जस्ट गॉस पीस है। अगर मान लीजिए आप फील्ड में हैं, यू कैन इवन यूज द क्लॉथ ऑफ द सेम पेशेंट, उसका कपड़ा फाड़ के आप उसका बना सकते हो, जुगाड़ मेथड, यू नो। Or you can use in the hospital, you can use a big gauze and you tie it like this, one knot, second knot, then you put a small pin and थोड़ा rotate करें so you have adequate pressure. Adequate pressure कब तक हम कहते हैं? जब तक आप करते रहिए जब तक आपकी bleeding ना रुक जाए, number 1. Number 2, patient start developing pain. क्यों pain होता है? When we do spraying, थोड़ा इस्कीमिया डेवलप होता है, ब्लीडिंग कम, इस्कीमिया। तो यू नो जस्ट उसको सांत्वना देना है कि भैया थोड़ा दर्द होगा लेकिन उससे आपकी जान बच सकती है। तो व्हाट इज द एंड पॉइंट? एक तो आप देखेंगे कि डिस्टल पल्स, जो मान लीजिए यहाँ पे जैसे हमने देखा ये फ्रैक्चर फीमर है और यहाँ पे यू नो दिस थिंग, तो डिस्टल पल्स लाइक पॉप्लेटियल एंड डॉर्सलिस पीडिस इसका ऑब्लिटरेट हो जाना चाहिए, नंबर 1। सेकेंड इज ब्लीडिंग रुक जानी चाहिए। अगर ब्लीडिंग नहीं रुका विद 1 टूर्निके, again 5 centimeter above the first tourniquet, you can put the second tourniquet, okay, second tourniquet in the space of 5 centimeter, ठीक है ना, समझ गए? It is life saving है on the field. We have seen so many patient dying, बस ये simplified method अगर हम नहीं करते हैं, patient will die. घर में भी हो सकता है, you should know this method. And military में it has really worked very nicely. You know, ये जो एक्स ABCD प्रोटोकॉल में बता रहा था, ये एक्चुअली मिलिट्री सेटिंग से लिया गया है। मिलिट्री सेटिंग उनमें कहते हैं इसे मार्च प्रोटोकॉल, मार्च, एम फॉर मैसिव हेमरेज। यू नो, आपने देखा होगा मूवीज में भी फट से बांध देते हैं, एंड दैट इज सेविंग लाइफ, ओके। सिंपल लाइक आप देखिए घर में अगर मान लीजिए आपका फ्रैक्चर हो गया, हाउ टू सेव? यू सी दैट, जस्ट पुट ए सिंपल कार्डबोर्ड ले लीजिए, घर में अवेलेबल है, एंड यू कैन पुट अ प्लिंट, one joint above and one joint below the suspected fracture, okay. And this is the third third image जो आप देख रहे हो, ये है pelvic binder जो मैं दिखाऊंगा। ये देखिए घर में अवेलेबल होता है बेडशीट, ओके। इन आवर हॉस्पिटल ऑल्सो हॉस्पिटल की शीट होती है। तो बिलो द ग्रेटर ट्रोकेंटर आपको ये बांधना है, पेट में नहीं बांध लेना है आपको। तो यू डोंट हैव टू यू नो पुट इट हियर इन द एब्डोमेन, यू हैव टू पुट इट ऑन द actually at the level of hip, जो हमारा anterior leg spine होता है, you know, just greater trochanter, just tie it like this, okay, adequate pressure, and थोड़ा सा I'll just go to the previous slide and you can see, you know, this both the limbs should also be tied like this, okay, tied like this along with the pelvic binder. This अगर आपको open book है या नहीं है, forget it, आपको pelvic compression test positive है, BP कम है, तो आप बांध दीजिए बिना एक्सरे के, okay. This is a procedure which we don't require any x-ray. Before, you know, doing x-ray, you need to do splinting, okay, and before x-ray only you have to do pelvic binder, क्योंकि एक्सरे के लिए जा ही नहीं पाएगा आपका पेशेंट। आप इमेजिन करिए कौन से डिस्ट्रिक्ट हॉस्पिटल हमारा बेड साइड एक्सरे है, एम्स में मिल जाता है, यहाँ पर हमारे यहाँ पर बहुत सी जगह नहीं है, समझ रहे हैं? तो उसके लिए वेट नहीं करना है, यू जस्ट पुट दिस, बीपी स्टेबलाइज हो जाएगा, फिर आप भेजिए, गो टू द रेडियोलॉजी, है ना, एंड किसी को साथ लेके भेजिए। अकेला मरीज अटेंडेंट के साथ अपने अटेंडेंट्स का जाना ही नहीं है। इसको एक नर्स को भेजिए या किसी को भेजिए। पेशेंट, सिक पेशेंट को फॉर गॉड सेक डोंट सेंड विद द अटेंडेंट, ओके। सो व्हेन यू गिव फ्लूइड ब्लड, हाउ डू यू नो कि आप पेशेंट ठीक हो रहा है? 1, टैकीकार्डिया आपका कम हो जाएगा, बीपी विल इंप्रूव। थर्ड, यूरिन आउटपुट, सबसे इंपॉर्टेंट मार्कर क्या है? थोड़ा, और जैसे टच करेंगे थोड़ा वार्म होना शुरू हो गया, पेशेंट ऑल्टर्ड सेंसोरियम में थोड़ा ठीक से बातचीत करने लगा, कैसे हो भैया? हाँ अभी थोड़ा ठीक लग रहा है, ठीक है ना। सो यू नो कॉन्शियसनेस आ गया इसका थोड़ा सा। एंड फोर्थ इज, यू सी द मोस्ट इंपॉर्टेंट इज यूरिन आउटपुट। थोड़ा डार्क कलर यूरिन पहले था इमीडिएटली, लो लेस एंड डार्क था पहले यूरिन, नाउ यूरिन कलर इज आल्सो बेटर एंड इज मोर इन नेम, मोर इन, दैट मींस व्हेन यू गिविंग फ्लूइड और ब्लड, ये मैन्यूवर करने के बाद इफ इट इज रिससिटेटेड वेल, सो इट इज इंप्रूविंग, उससे आप इंप्रूव कर, यूरिन आउटपुट बिल्कुल आप करेंगे, है ना। यूरिन पोलिस कैथेटर डालने का ओनली कैविएट ये है कि ट्रॉमा में अगर ब्लड मियाटिस में है, यू नो, मियाटिस वेजाइनल वॉर्ड और यूरेथ्रल मियाटिस में, तो पोलिस कैथेटर नहीं डाल, ओनली दैट इज ओनली कैविएट. So this shock management we can also apply in upper GI bleed, ruptured, ectopic, okay, postpartum hemorrhage. Beside postpartum hemorrhage और भी उसके अलग methods हैं. So but fluid blood, this thing is same in most of the thing. Obviously in postpartum hemorrhage you have to give other, you have to give drugs like tranexamic acid, syntocin and all that. So the last part of my talk जो मैं बोलना चाहूंगा शॉक मैनेजमेंट के लिए, wherever possible, remember if you are a medical college, please discuss with your blood bank to have a massive hemorrhage protocol. The biggest killer in critically ill and injured patients are hemorrhage. Okay, so blood is like a drug for them, for us, for this patient, like with bleeding. सबसे बड़ा ड्रग क्या है? वही है, blood is a drug. अब उसको बहुत सीरियसली लेना चाहिए, so remember this. We know that blood banks through the AIMS नीति study up to 2 o'clock बहुत जगह फंक्शनल है, 2 के बाद नहीं होता. That is number 1. Number 2 is जहाँ पे ब्लड बैंक है, प्लीज डिस्कस विद देम, क्रिएट ए सिस्टम. ओके, सिस्टम आप बनाइए, मुझे मैसिव हेमरेज प्रोटोकॉल लागू करना है अपने सीवियरली ब्लीडिंग पेशेंट्स. तो व्हाट शुड बी आवर प्रोटोकॉल? तो आप उसके मैं 7 स्टेप्स बताऊंगा अभी नेक्स्ट स्लाइड्स में कि व्हाट आर द 7 T's ऑफ मैसिव हेमरेज और मैसिव ट्रांसमिशन. तब आपको जरूरत पड़ी. ट्रॉमा में कहते हैं ईच 1 minute डिले इंक्रीजेस द मोर्टेलिटी. और अर्ली आइडेंटिफिकेशन, किसको ब्लड जरूरत है, बहुत ही इंपॉर्टेंट है हमें पता लगाना. और ये MHP अगर हम इंप्लीमेंट करेंगे, नॉट ओनली इट विल इंप्रूव पेशेंट आउटकम, ओवरऑल ब्लड यूटिलाइजेशन भी इंप्रूव करती है, कॉस्ट सेविंग भी होती है. तो हम व्हाट वी डू, this is at the slightly higher level in the medical college or in the district hospital level. If you have that, the 3 components हम देते हैं, 1:1:1 ratio. ठीक है ना. बेसिकली कहने का मतलब है कि आप फ्लूइड ब्लड फॉर ब्लड जो हम कहते हैं, पढ़ते आ रहे हैं MBBS लेवल से, जल्दी शुरू करना, जितना जल्दी जहां हो पाए. तो सपोज मैं मानता हूँ, गिव यू सिनेरियो, टर्शियरी केयर लेवल हॉस्पिटल है, ब्लड बैंक है, राउंड द क्लॉक चल रहा है. So what we can do this, PRBC, that is a pure RBC, fresh frozen plasma और प्लेटलेट की कॉम्बिनेशन हमें देना है इन सीवियर हेमरेजिक शॉक ड्यू टू ट्रॉमा पेशेंट में देते हैं. अगर ट्रॉमा नहीं है तो आप ओनली PRBC आप देख सकते हैं. तीनों का रेशियो आप देखना, FFP ब्लड से जाने बची हैं. इसीलिए हम कहते हैं सबसे फर्स्ट फेज में कैसे शुरू किया जाता है ना. पहले तो आप इमीडिएटली दीजिए कि जो पेशेंट आया, अगर मान लीजिए फीमेल पेशेंट है, तो आपको O नेगेटिव, अनक्रॉस O में नेगेटिव ब्लड देना है. फीमेल पेशेंट ब्लीडिंग पेशेंट है तो O नेगेटिव, पर O नेगेटिव बहुत रेयर है, समझ, रेयर ब्लड ग्रुप है. अगर वो नहीं मिला तो O पॉजिटिव भी दे सकते हैं. फर्स्ट थिंग इज, एज सून एज द पेशेंट कम्स, आप इमीडिएटली 2, अगर O नेगेटिव में 2 अनक्रॉस मैच दीजिए O पॉजिटिव वाला. देन यू डू व्हाट इज कॉल्ड एज सलाइन क्रॉस मैच, और उसके बाद क्रॉस मैच. तो इनको हम जो मैसिव हेमरेजिक प्रोटोकॉल कहते हैं, हाउ डू यू, कौन से पेशेंट में देना है, दैट इज नंबर 1. ओके, कौन से पेशेंट में देना चाहिए? देखिए, जो पेशेंट हाइपोटेंशन है, टेकिकार्डिया है, एंड प्लस अगर मान लीजिए देयर इज इन ट्रॉमा पेशेंट देयर इज ब्लीडिंग इन द एब्डोमेन. ओके, एब्डोमेन ब्लीडिंग है, किसी ने चाकू से मारा है. ओके, दिस इज अ पेशेंट, अनस्टेबल पेशेंट, रिक्वायर्स मैसिव हेमरेज प्रोटोकॉल. बहुत सारे स्कोर्स हैं, ये जो स्लाइड दिख रहा है आपको, ABC स्कोर, RABT स्कोर, ये तो भूल जाइए, आपको इतना कॉम्प्लिकेट करने की भी जरूरत नहीं है. आपका भी 6 सेंस है, फिजिशियंस का हमारा 6 सेंस होता है. सब फिजिशियंस का, जो हमारे डॉक्टर्स का 6 सेंस होता है, कौन से पेशेंट में देना है. हाइपोटेंशन है, टेकिकार्डिया है, फ्लूइड भी दिया आपने, 1 लीटर दे दिया, फिर भी बात नहीं बन रही है, तो आप ब्लड मंगाइए इमीडिएटली. ये हमारा रिफ्लेक्स है, हम डेली हम काम भी करते हैं। अब इसके लिए हमें ट्रॉमा में थोड़ा सा उसको ऑर्गेनाइज कर दिया है। तो इन ट्रॉमा भी से एबीसी स्कोर, एबी क्या मतलब, एबीसी मीन्स असेसमेंट ऑफ ब्लड कंजम्पशन स्कोर। ओके, दीज आर, मैं ये स्लाइड स्किप करूंगा, आप लोग इसको जरूरत नहीं है। कहने का मतलब है आपने ढूंढ लिया है ब्लीडर कहाँ से हो रही है, जैसे फास्ट पॉजिटिव, एब्डोमेन ब्लीडिंग हो रही है, पेल्विक फ्रैक्चर है, फ्लूइड से रिस्पॉन्ड नहीं कर रहा है, गेट आउट। और यही पेशेंट मैसिव हेमरेज प्रोटोकॉल लागू किया जाता है। याद रखिए, ओनली सिंपल फ्रैक्चर फीमर से हाइपोटेंशन करके आया तो यू जस्ट गिव फ्लूइड एंड 1 or 2 units ऑफ ब्लड, बिकॉज 750 ml ही लॉस हुआ है, तो पेशेंट विल रिस्पॉन्ड। बट पेल्विक फ्रैक्चर में, हीमोपेरिटोनियम में, पेशेंट विल नॉट रिस्पॉन्ड, गेट एमएचपी। ओके, तो नेक्स्ट टी ट्रिगर आपका हो गया, कब बुलाना। सेकेंडली टीम, यू हैव अ टीम, गो बैक एंड टॉक टू योर एमएस, मेडिकल सुपरिटेंडेंट, आप बात करिए, आई वांट अ टीम। तो मेडिकल एमएस कैन मेक हेल्प यू टू कोऑर्डिनेट विद इमरजेंसी डिपार्टमेंट, ब्लड बैंक, सर्जिकल टीम और लेबोरेटरी टीम। बैठ के आप एक प्रोटोकॉल बनाइए कि जब हम ट्रिगर करें हमें इमीडिएटली ब्लड आना चाहिए, ये एसओपी होना चाहिए। तो ये आप जाके बनाइए, एक टीम कॉन्सेप्ट, अकेले नहीं करना है, अकेले कोई हीरो नहीं बन सकता, नोबडी अलोन इज अ हीरो, द टीम इज द हीरो। ओके, तो हैव द टीम कॉन्सेप्ट इन एबीसी रिससिटेशन। नेक्स्ट टी, थर्ड टी आ गया अभी। थर्ड हमारी जो टीम में टी है, दैट इज अवेलेबल एवरीवेयर, पीएचसी में भी अवेलेबल है ना। मैं जानता हूं आप रिस्पॉन्ड कर सकते हैं चैट में, आपके पास सबके पास अवेलेबल है, पीएचसी में, सीएचसी में, सब जगह अवेलेबल है। ट्रेनेक्सा क्यों अवेलेबल है, हमारे एमसीएच प्रोग्राम के लिए, करेक्ट, ठीक है ना, पोस्टमार्टम हेमरेज में हम देते हैं, बट यहाँ पे हमारा ट्रॉमा में भी दे सकते हैं, और दूसरा हमारा पीपीएच में दे सकते हैं, बहुत इंपॉर्टेंट है, ठीक है ना। पीपीएच में वुमन ट्रायल था, एक वुमन ट्रायल, तो उसके वजह से हमने पीपीएच में दे सकते हैं, है ना, 1 ग्राम बोलस एंड 1 ग्राम ओवर 8 आवर्स। सिमिलरली ट्रॉमा हेमरेजिक, ट्रॉमा, चोट लग गई, ब्लीडिंग हो रही है और बीपी लो है, और विद इन 3 आवर्स चोट लगी है, चोट लगी मान लो 3 घंटे पहले लगी, विद इन 3 आवर्स अगर चोट लगी है, ब्लीडिंग हो रहा है, बीपी कम है, बीपी कम नहीं होने से मत दीजिए फॉर गॉड सेक, है ना। तो विद इन 3 आवर्स आपको देना है, तो ये आप 1 ग्राम बोलस और दे सकते हैं, और 1 ग्राम ओवर 8 आवर्स दे सकते हैं, और यू कैन गिव डायरेक्टली 2 ग्राम बोलस, न्यू गाइडलाइन, नया गाइडलाइन कहता है 2 ग्राम बोलस भी दे सकते हैं। बट कब नहीं देना है आपको पता होना चाहिए। ट्रॉमा है ना, पेशेंट है, बीपी कम है, लेकिन 5 घंटा हो गया, 5 घंटा पहले चोट लगी थी, मत दीजिए। ओके, डोंट गिव, बिकॉज इसके साइड इफेक्ट्स, इट कैन कॉज थ्रोम्बो एम्बोलिज्म, इट कैन कॉज डीवीटी। ओके, तो यही जो ट्रायल था, मैं इसको स्किप करता हूं, यही ट्रायल से, क्रैश टू ट्रायल से पता लगा, 20,000 पेशेंट्स का पूरे दुनिया में लिया गया था, वी आर पार्ट ऑफ दिस ट्रायल ऑल्सो, ठीक है ना। तो उससे जानें बची हैं, ब्लीडिंग कम हो जाती है और जान बचती है, तो आसानी से अवेलेबल है सारे पीएचसी, सीएचसी, डिस्ट्रिक्ट हॉस्पिटल, इतना तो हम कर ही लेंगे। पर थोड़ा बहुत यहाँ ब्लीडिंग हो गया, इधर हो गया, मत दीजिए ट्रेनेक्सा, वो वेस्ट है। नेक्स्ट टी, टेम्परेचर, जब आप ना फ्लूइड ब्लड दे रहे हो और चोट भी लगे, यू नो, देयर इज टेंडेंसी टू डिक्रीज ऑफ, यू नो, क्या कहते हैं, टेम्परेचर, टेम्परेचर कम हो जाती है, यू नो, बॉडी की, क्योंकि ट्रॉमा है, ब्लड लॉस हो गया, वार्म ब्लडेड ह्यूमंस, राइट, जब ब्लड लॉस होता है हमारा हीट भी लॉस होता है, इवन इन हॉट समर पेशेंट विल डेवलप हाइपोथर्मिया, और इतना हम वार्म फ्लूइड और ब्लड देते हैं, ब्लड वैसे ही ठंडा होता है, ठीक है ना, तो इट कॉज हाइपोथर्मिया, तो मॉनिटर दैट। नेक्स्ट टारगेट है कि आपको कुछ लैब पैरामीटर्स करने पड़े, देन व्हेन टू टर्मिनेट, पेशेंट ठीक हो गया, इंप्रूव हो गया, ओके, बीपी आपका एचबी ऊपर आ गया, हीमोडायनामिक ठीक हो गया, आप इसको बंद कर सकते हैं। तो ये जो है आपने देखा, ए बी एंड सी, सबसे इंपॉर्टेंट हमारा रहा आफ्टर ए, फिर बी एंड थर्ड सी। सी इज हमने ठीक किया, इसके लिए जरिए चेन ऑफ सर्वाइवल, चेन ऑफ सर्वाइवल जो हम कहते हैं, प्री हॉस्पिटल केयर से लेके अस्पताल तक पूरा एक चेन है ना। तो ये आप देख सकते हैं, इसको आगे आप पढ़ सकते हैं, ठीक है, ये स्लाइड मैं शेयर भी कर दूंगा रंजीत जी से, तो यू कैन जस्ट गो थ्रू, ये डिफिकल्ट टू टीच इन दिस थिंग, राइट फ्रॉम हाउस, घर में अगर मान लो ब्लीडिंग हो रही है, तो घर में क्या करना है आपको इमीडिएटली, आप टूनी के बाद डायरेक्ट प्रेशर टूनी के। एम्बुलेंस में क्या करेगा, when it reaches the emergency department, what you have to do and what you have to do as a surgeon. Understood? So all these components will save the life, and this is called as chain of survival for hemorrhagic shock. This is also applicable for a bleeding mother. Okay, we lose a lot of patients, bleeding mother, which is a, MCH program has really done wonders. It has decreased mortality because of very उनका लक्ष्य प्रोग्राम एक प्रोग्राम की तरह चल रहा है, and that has reduced mortality. Same thing we can also apply for other emergencies, madam. Other emergencies, stroke, STEMI, trauma, other emergencies, snake bites. उन्होंने एक system बनाया. So we can take good help of the system which MCH program बनाया. Same चीज, my fellow colleagues who are listening to me, let us make emergency care system that way. And last few slides, as they say, after you have done A, B, C, look at disability. Please look at the conscious level of the patient. Patient conscious है, unconscious. इसको चेक हम कैसे करेंगे? इसको हम ग्लासको कोमा स्केल से कर सकते हैं, थोड़ा डिफिकल्ट है, सीखना पड़ेगा. और you can do ABPU scale. ABPU. A for alert. Okay, patient alert है क्या? अरे भाई कैसे हो? B. B is for verbal response. आप पूछिए, अरे भाई कैसे हैं? तभी जवाब दे रहा है. That is B. Third, आपने पूछा P. P is for pain. जब आपने दबाया ऐसे, ये ऐसे इधर दबाइए. लोग कहाँ दबाते हैं? हम जनरली यहाँ दबाते हैं. ओके, ऐसे दबाते हैं. कई लोग तो थप्पड़ भी मारते हैं, ठीक है ना? तो ये नहीं करना है. और कान चिमटा मारते हैं कई लोग. तो that is not the way to assess the conscious level. Please do this way, supraorbital ridge, as per the classical description. Okay. So and the last is U. U is unresponsive. कुछ भी आप दवाई जोर से करें, कोई जवाब नहीं दे रहा. That means patient बहुत serious, unconscious है, maybe head injury. Okay, head injury है. ABC आपने ठीक किया, stabilize हुआ, फिर भी आपका unconscious है, it may be head injury. Okay, AVPU. And the last is E. भाई पेशेंट ब्लीड कहाँ से कर रहा है? जनरली हम अनड्रेस नहीं करते पेशेंट. तो अगर चोट वाला विक्टिम है, प्लीज अनड्रेस द पेशेंट irrespective whether is a male or female. Obviously उसको आप immediately confidentiality होना चाहिए, पर्दे के अंदर होना चाहिए, कंबल उसको उड़ाइए और करिए. इससे ना बहुत हिडन ब्लीडर्स जो है ना मिल जाते. हिडन ब्लीडर्स बाहर ही नहीं दिखेंगे, बट उल्टा करके देखेंगे तो मिल जाते. और द लास्ट thing is आपको immediately send routine investigation. Okay, emergency investigations on HB, platelet count, urea electrolyte, blah blah, plus immediately send for grouping, cross matching. Okay, basic things you can do. And अगर elderly है, more than 40, they say more than 40 years अगर trauma में है तो do a ECG. Okay, after you stabilize the patient, आपका patient अब बच गया. अब आप खाली एक करेंगे हेड टू टो एग्जामिनेशन है फॉर एनी ब्रोकन लिम्स. कहाँ पे ब्रोकन बोन्स हैं उसको आप पाल्पेट करिए, पता लगाइए. Sometime you find this kind of injury in the leg. Okay, अब you can see. So this is a wound. Okay, which will distract patient. ऐसे wound करके आते हैं. Okay, यहाँ से bleed होता है, shock, right? So what happens is suddenly ऐसे bleed, पूरा अटेंशन क्या होता है, सारा लेग में चला जाता है. ओके, और पेशेंट ऐसे भी आते हैं. देखिए ऑल ऑफ पेशेंट आते हैं ऐसे, वैसे ऐसे आ रहे होंगे, ऐसे नॉइजी ब्रीदिंग होगा, और पेशेंट ऐसे सांस भी ले रहा होगा. ओके, पेशेंट कोल्ड क्लाइमी भी होगा, लेकिन आपका दिमाग कहाँ जाएगा? वो बैड वुंड पे जाएगा. ऐसे वुंड पे सीधा आपका नजर जाएगा. आप भूल जाएंगे कि इसको एयरवे कॉम्प्रोमाइज है. एंड पेशेंट मरेगा कैसे इसमें? नॉट बिकॉज ऑफ द जो लेग में वुंड है, ही विल डाई ड्यू टू एयरवे प्रॉब्लम. ओके, तो इसे हम कहते हैं डिस्ट्रैक्टिंग इंजरीज, आपका ध्यान भटकाने वाला इंजरी. तो आप ध्यान मत भटकाइए. यू गो टू फर्स्ट एयरवे. फर्स्ट इज एक्स ABCDE, समझ ना? एक्सैंग्विनिटी है ABCDE. ओके, so you don't forget that. Last is the last sign is fifth vital sign, which is called relief of pain. Pain medication please दीजिए. Don't give vocal anesthesia. अरे भाई कुछ नहीं होगा. Generally हमारा एक attitude होता है कुछ नहीं होगा. हम हैं कुछ नहीं होगा. Please don't do that. Assess the pain. Pain assessment करिए आप. अरे भाई अगर मान लो 100% अगर मान लो आप क्वांटिफाई करिए पेन ना. आप बताइए अगर मान लो 100 रुपए अगर है तो बहुत ज्यादा पेन हो रहा है. अगर आपके पास 0 पैसा है, बिल्कुल ही नोट नहीं आपका, 0 पेन है, तो आप बताइए कि कितना पैसा का दर्द हो रहा है. तो ही विल टेल समथिंग एंड गिव द पेन मेडिसिन. ओके. तो लास्ट स्लाइड सी दिस. सिंस वी आर, हम जो स्टडी कर रहे हैं अभी कंट्री में भी, जैसे मैंने कहा कि हम एक मॉडल बना रहे हैं, इमरजेंसी या ट्रॉमा केयर मॉडल बना रहे हैं कि क्या सर्विसेज कैसे इंप्रूव करने, है ना. कितना आप कर सकते हो पीएचसी लेवल पे, एसडब्ल्यूसी लेवल पे, सीएचसी पे, डिस्ट्रिक्ट हॉस्पिटल में, कितना मेडिकल कॉलेज में कर सकते हो, इंटर हॉस्पिटल रेफरल में आप कैसे कर सकते हो, 108 को कैसे यूटिलाइज कर सकते हो, कम्युनिटी को कैसे अवेयर कर सकते हो ताकि अस्पताल आने से पहले ही ब्लीडिंग रुक जाए, है ना. बाय द टाइम आपके पास आएगा तो पेशेंट मर भी सकता है. तो व्हाट यू कैन डू, कम्युनिटी अवेयरनेस कैसे कर सकते हैं, लाइक सिंपल थिंग लाइक स्टॉपिंग ब्लीडिंग, स्प्लिंटिंग, यू कैन डू एट होम. तो इसके साथ में मॉडल अभी चल रही है जर्नी 57 हॉस्पिटल जैसे मैंने बताया. इसमें जो आपको बता के मैं ये एंड करूंगा कि हमने जो ये टीचिंग ट्रेनिंग ये जो हमने किया एबीसी, यही जो स्लाइड्स है हमने सीएचसी सागली में किया. सागली बोल के एक छोटा सा कम्युनिटी हेल्थ सेंटर है. तो उन्होंने पहले 1 साल पहले उनको भी ये रिससिटेशन वगैरह नहीं करते थे ना. स्नेक बाइट का एग्जांपल दूंगा, बाहर से स्नेक बाइट बाहर से बाहर भेज देते थे. तो आफ्टर टीचिंग ट्रेनिंग एंड दिस थिंग, शॉक पेशेंट, कॉमन इमरजेंसीज को इन ए ईयर टाइम दे हैव एक्सपोनेंशियली इम्प्रूव देयर केयर लेवल. कोई एक्स्ट्रा नहीं दिया उन्होंने. सेम फॉर टीचिंग, रीऑर्गेनाइजेशन ऑफ इमरजेंसी रूम, ट्रियाज, 3R मॉडल जिसे हम कहते हैं रिकॉग्निशन, रिससिटेशन एंड टाइमली रेफर. 3R का मंत्र दिया. रिकॉग्निशन, पेशेंट इज सिक, टाइमली रिससिटेशन जो अभी हमने पढ़ाया आपको, थर्ड इज टाइमली रेफरल. अस्पताल के अंदर एक्सपर्ट्स हैं तो दीजिए, नहीं तो टाइमली नियरेस्ट हॉस्पिटल को सेफ ट्रांसफर आप करें. तो इससे ही इंप्रूव बहुत हो गया मैडम. और डीएमओ जो हमारे डीएमओ थे अरुणाचल के पापुमपारे डिस्ट्रिक्ट के, शी सेड इन नेशनल मीटिंग कि ज्यादा कुछ नहीं किया एमपी में, ये हमने रिऑर्गेनाइजेशन में एक्स्ट्रा दिया भी नहीं, है ना. तो दैट हैज रियली हेल्प. उन्होंने एक मॉडल बन गया सीएचसी सागली मॉडल. अभी पूरे डिस्ट्रिक्ट में वो अरुणाचल में अभी पूरे एज ए मिशन बोर्ड में कर. तो दिस इज द लास्ट स्लाइड जो मैं बताया कि एबीसीडी मैनेजमेंट व्हाट यू कैन डू एट एचडब्ल्यूसी लेवल, पीएचसी लेवल, सीएचसी लेवल. दिस इज आवर नेशनल प्रोजेक्ट का हिस्सा है. आई शेयर द स्लाइड्स. So you please go through everybody what we can do and we can do it together because this is we are in a mission board. अभी आपने देखा भी होगा प्राइम मिनिस्टर मोदी ने रिसेंटली उन्होंने बजटरी अनाउंसमेंट किया है टू स्ट्रेंथन इमरजेंसी एंड ट्रॉमा सर्विसेज एट द डिस्ट्रिक्ट हॉस्पिटल लेवल अक्रॉस द कंट्री. फिर हमने क्या किया, द एक्सपर्ट इन दैट वेबिनार, फिर उसको बजट को यूटिलाइज करने एक वेबिनार हुआ जिसमें मोदी जी ने बोला. उसके बाद हम सारे एक्सपर्ट नीति आयोग के साथ बैठ के एक मॉडल उनको गाइडेंस डॉक्यूमेंट हमने बना दिया मैडम 1 महीने में. अभी हमने 1 महीने यही किया तो ताकि ये बजटरी रिक्वायरमेंट के कैसे यूटिलाइज हो. तो इसमें मेन हमने रखा है कि कैसे स्किल ट्रेनिंग करनी है हमारे ह्यूमन. मेन प्रॉब्लम होती है हमारी, कई जगह हमने देखा है कि सब कुछ होते हुए भी आउटकम अच्छा नहीं है ना. और हमने ये देखा और हमने ये भी देखा कि हमारी स्टडी में कम से कम लोग और ये होके भी थोड़ी सी ट्रेनिंग, थोड़ी सी मॉडलिंग से भी उसी एक काम हो गया. सीएचसी सागली मॉडल ऐसे करके हमने वो किया. तो जब आप काम करते हुए दिखाते हो, उनका पूरा गवर्नमेंट ऑफ अरुणाचल अब उनको सपोर्ट कर रहा है, एक्स्ट्रा स्टाफ दे रहा है. पहले हमें करके दिखाना. So I think it is a good thing. I am very thankful to NHSRC and thank to Kotwal sir, you know, for also sharing his thoughts in this in the national project and given me this opportunity to speak before you. I spoke about resuscitation, transfer. Enough has been spoken by our previous panelists. whenever you do transfer, मेरा खाली एक ही चीज कहना है कि आप दूसरे फैसिलिटी को भेज रहे हो, आप प्रॉपर आप उसको क्लिनिकल डिटेल्स दूसरे हॉस्पिटल को फोन करके बताइए, सिक पेशेंट है के बारे में बताइए, और जिसे हम कहते हैं बोल के भेजिए। हमारे देश में क्या ना, किसी को बोल के भेजने का कोई सिस्टम नहीं है, हमारे एम्स में भी नहीं है, ठीक है ना। मैं एम्स में प्रोफेसर हूँ, मैं खुद बता रहा हूँ कि हाँ हम बोल के नहीं भेजते, ठीक है ना। बट दैट इज नॉट ए गुड सिस्टम इन आवर कंट्री। वी शुड इन्फॉर्म एंड ट्रांसफर। और किस लिए इन्फॉर्म कर रहे हो, आप बोलो मैंने इतना कर दिया सर, मेरे को लगता है ये सर्जरी वहीं पे होएगी, आप इसीलिए हम भेज रहे हैं, तो दैट रोज रिसीविंग फैसिलिटी भी वो भी तैयार रहेंगे आपके मरीज के लिए वो करने के लिए। तो इट इज ए गुड सिस्टम, इन्फॉर्म ट्रांसफर इज वेरी गुड, एंड लेवल ऑफ केयर जो है हमारे को इन्वॉल्व द 108 सर्विस और 112 सर्विस विच एवर यू हैव इन योर दिस थिंग, उनसे बातचीत करिए। वी डोंट स्पीक टू आवर एम्बुलेंस पीपल, वो आके बाहर ही छोड़ के भाग जाते हैं। नो नो सर, जो भी आप फिजिशियंस हैं अभी सुन रहे हैं मेरे को, प्लीज टॉक टू योर पैरामेडिक। उनको भी 11वीं 12वीं पढ़े हुए बच्चे होते हैं, उनको नहीं पता जाता, तो आप उनको बताएंगे इसको अगली बारी ऐसा करके लाओ, वो भी अच्छा करके लाएंगे। ओके, तो आप उनसे कनेक्ट करिए, बातचीत करिए, ताकि नेक्स्ट पेशेंट आपका अच्छा लेके आएगा वही पैरामेडिक। ओके, एंड एवरी 2 to 3 months कॉल द 108 ऑपरेशनल हेड टू योर हॉस्पिटल। मुझे पता है कि CHC DH सब डॉक्टर्स जुड़े हुए हैं इसमें, और 1-2 एम्बुलेंस पार्क होती है आपके वहाँ अस्पताल में, तो इंस्टेड बाहर बैठने की जगह एम्बुलेंस में आप अंदर बिठाइए इमरजेंसी में, वहीं से वो कॉल के लिए चला जाएगा, तो दैट आपका सेफ ट्रांसफर भी हो, और उसको अच्छा वो भी आपसे सीख लेगा इमरजेंसी में बैठ के, जब वो कॉल आएगा चला जाएगा वहां से। तो दिस इज व्हाट आई वांटेड टू से, इज खाली लर्न करना स्किल, ये थियरी एस्पेक्ट इज नॉट इम्पॉर्टेंट, यू टू लर्न द होल सिस्टम। एंड जो हमने थोड़ा बहुत आपसे शेयर किया, आई एम श्योर यू वुड हैव हेल्प्ड यू, एंड थैंक यू वेरी मच।
Thank you, Dr. Sanjeev, for such a good, in simple way. You reminded us all the do's and don'ts very clearly. I hope all the participants, as you see in the chat box, they are already appreciating this very much. I just, want to, it's not a question. Could you just highlight once more regarding that, putting up of ligation or tourniquet, because in snake bite they say big no to that, because they fear that it will interfere with the blood supply. It will be lead to ischemia. So there is a pressure immobilization technique is there. So could you just once again explain that, because putting up it not put correctly, this may harm the patient.
Yeah, very good question, madam. Definitely, it is not to be used in snake bite. आपने बिल्कुल सही कहा, and that point is very valid. But in bleeding patient due to trauma, so what you do is you use just 5 centimeters. Suppose the bleeding is occurring here, just 5 centimeter, above the spot wound. Okay, just you tie a tourniquet instead of, you can take a big long roll of gauze piece, gauze roll leke, you just make one knot. Okay, two loose knots, two knots you put. Okay, and then you put a small pen, small pen in between, and rotate it, so to create enough pressure, so to obliterate uska jo end point hai, so it should stop, the bleeding should decrease and it should stop from the wound. This is a very practical way. Second is you can put 2 fingers, वो टूनी के नीचे आप देख सकते हैं, adequately आपका जाना चाहिए, ठीक है ना। And third is the, suppose I am putting tourniquet here, so my vessels, radial artery of this thing, it should be it should become feeble. Okay, so it should become less. So, and immediately go to the health facility. So this is what the thing is, and this is enough to decrease that arterial bleed. Venous bleed में तो आप direct pressure से भी आपका काम हो जाएगा. Venous bleed है तो अपने आप direct pressure लगाएंगे, so it will stop. After 5 to 10 minutes आप लगा के रखिए, 10 minutes of pressure band दे के रखिए, it will stop on its own. Okay, only for arterial bleed. Spurter आ रहा है तो please do that. Tourniquet is not for every patient who is bleeding. ठीक है ना, बस वीनस सूजन सिंपल ऊज होके आ रहा है, तो आप डायरेक्ट दबा के रखिए, फिर भी नहीं ठीक हो रहा, देन यू टाइट. फर्स्ट स्टेप इज डायरेक्ट प्रेशर, नॉट टूनिकेट. फर्स्ट डायरेक्ट प्रेशर, if it does not stop 5 centimeter above the wound, उससे भी स्टॉप नहीं हो रहा, तो another tourniquet you can put another 5 centimeter above the, so up to 2 tourniquet you can put. Okay, so if you do it a longer time, it can cause ischemia of the limb. उसका flip side ये है कि पूरा limb ischemic भी हो सकता है, तो उसका ध्यान रखना है. बट इमीडिएटली नियरेस्ट हॉस्पिटल को आप ले नियरेस्ट, तो दैट वो आर्टेरियल ब्लीड को लाइगेट करके ध्यान रखें. तो दैट इज द थिंग. अगर लॉन्ग ट्रैवल टाइम है तो डिपेंड्स है ना, तो आपको देन यू हैव टू सेव लाइफ और लिम्ब, देयर आर टू थिंग्स. सपोज लॉन्ग ट्रैवल टाइम, दे सपोज अरुणाचल आई एम टॉकिंग अबाउट मैडम ना, दे उनको तो एक जगह दूसरी जगह जाने में 4 घंटा लगता है और बीच में हेल्थ फैसिलिटी नहीं होता, ठीक है ना, तो देयर इज नो चॉइस. बाय टाइम द टूर्निकेट यू मे लूज द लिम्ब, क्योंकि लंबा टाइम होगा, इस्केमिक टाइम 6 घंटा होता है ना. मान लीजिए अरुणाचल में लंबा टाइम है आपका, एक जगह दूसरे पहाड़ जाने में आपको 6 घंटा लग जाता है, एक ही दिन लग जाता है. बट उसमें आपको डिसीजन ये लेना है, फर्स्ट लाइफ देन लिव, फर्स्ट लाइफ देन लिव. अगर अदरवाइज क्या होता है ना, पेशेंट विल ब्लीड टू डेथ. इंसान जिंदा रहेगा तभी तो लिम्ब की जरूरत है. तो दैट इज व्हाट इट इज ए द प्रिंसिपल फॉर ऑल द कॉलीग्स हियर, फर्स्ट लाइफ देन लिव. इफ बोथ आर स्टेक, फर्स्ट टेक लाइफ, सेव द लाइफ. अगर दोनों ही आप लगता है कि तराजू में हैं, जैसे अभी मैडम ने एग्जांपल दिया, फर्स्ट लाइफ एंड देन you have to sacrifice the limb for.
Yeah, I think the guidelines are very clear. If you think that there is a delay of more than 3 hours, certainly even in snake bite cases, it is advocated. But you need to take all those precautions. Dr. Sanjeev just now, demonstrated that how to do that pressure immobilization. So they, please go through that and follow those, and perhaps you can save both life and limb both, if you do it correctly.
So for snake bite, madam, for everybody, you can put a splint rather than tying a tourniquet. Just make a immobilization of splint. जैसे हम फ्रैक्चर में स्प्लिंट लगाते हैं, तो यू कैन पुट ए स्प्लिंट ऑन द बिटन लिम्ब एंड ओवरऑल थोड़ा सा आपको उसको रैप अप करना है, नॉट टाइटली, बट बेसिक आइडिया इज टू नॉट टू मूव द लिम्ब इन स्नेक बाइट, यू नो. तो बाय टाइंग ए टोर्निकेट क्या होता है, सारा वेनम नीचे हो जाता है, जैसे आपने एक्सप्लेन किया मैडम पहले, so it will be local venom will be staggered and local envenomation, local cellulitis, secondary infection due to in case of snake bite, and that will cause more damage to than the venom itself. And जब आप रिलीज करेंगे, खोल देंगे टूनिकेट, suddenly the local systemic envenomation patient die.
There is a technique to release this also.
Yes madam, yes madam.
It is not that you just like that you will remove
Yes
it.
madam, yes.
I think we had a very wonderful session. There's one question about single bone versus double bone. Makes any different? I don't know. I
Yeah,
think
yeah. Single bone means what madam?
क्वेश्चन इनकम्प्लीट है, परहैप्स वो स्प्लिंटिंग की बात कर रहे हैं, आई डोंट नो.
Yeah, so single bone, see, the thing is, just a minute, single bone versus double bone. No, doesn't make any difference. So only thing is, suppose you say hemorrhagic shock. Hemorrhagic shock जो होता है ना, is mainly due to bigger bones like fractured femur. Okay, femur is a very strong bone and it can cause hemorrhagic shock. 750 ml blood is lost. The other question is, I think that what one of our colleagues is asking is single bone and double bone, does it cause hemorrhagic shock? Yes, there are multiple. अगर आपका fracture femur नहीं है, I've seen many patients. So where smaller bones, small means not like femur, maybe tibia, okay, humerus, upper limb bones are broken, lower limb are broken, but not the femur. Still they can cause hemorrhagic shock, because each bone fracture will lead to up to 250 ml of blood loss. Okay, 250 ml. So आप वो myth में नहीं रहे कि खाली बड़ा bone टूटने से ही हो सकता है. So I think you are asking that. I think second is maybe you are asking about splinting. So again, one or two bone does not make a difference. Even if it is a one bone, you have to splint. Splinting will help you two things. One, it will prevent further hemorrhage from the from the vessel. Okay. Second is it will reduce pain. फ्रैक्चर हो गया है, अगर आप स्प्लिंटिंग कर देंगे, हिलेगा नहीं तो पेन भी नहीं होगा, हिलेगा नहीं तो आपका जो वेस्टर न्यूरोवैस्कुलर ट्री है वो कटेगा नहीं, so you'll not have, you'll have the safety aspect is important, no? Otherwise you can neurovascular thing, if it gets cut, then you will have a problem. So both for preventing hemorrhage, reducing the pain, that's why you must splint the patient one joint above and one joint below the area of fracture.
There is a question about how do you give pressure for a shoulder trauma, scapula fracture with bleed?
So you can give direct pressure. Direct pressure with the bleeding, open wound is there, if there is bleeding. So you can put gauze piece, take a gauze piece and you give direct pressure. Direct pressure, okay? So your question should have been, what you do if there is a bleeding in the neck, okay? यहाँ पे मान लो bleed हो रहा है, right? जैसे हम कह रहे हैं कि क्वेश्चन सवाल पूछ सकते थे, जैसे मैंने कहा टूर्निके बांधना है, राइट? टूर्निके मैंने बोला कि 5 centimeter above the limbs, right? That is what I said. So suppose there is bleeding here, तो क्या आप टूर्निके बांधेंगे गले पे? You'll kill the patient, right? So this is called as non-compressible parts. Okay, the bleeding from non-compressible parts like neck, axilla, okay, or in a thigh, in a groin, right? These are the non-compressible part where you can't do any, tourniquet. So what you can do is pressure dressing. You can do. You can give a pressure dressing here, and there is what is nowadays we have got hemostatic agents. Hemostatic agents आजकल available हैं. They are in like chitosin. Okay, chitosin के नाम से आता है. Chitosin is a generic name of that hemostatic agent. There are many hemostatic agents are powder form में available हैं. So if you have a wound here, okay, and which is bleeding, okay, not arterial bleed. Arterial bleed है तो you have to ligate. Remember that wherever it is, scalp, here, everywhere, right? So you should know the technique to pick the artery process, तो artery उठाइए and ligate करिए. So it will prevent the bleeding. If it is venous wounds, direct pressure करिए, फिर भी नहीं रुक रहा है, so not everywhere it is available. If somebody has a powder form, you can use that. But generally आपके hospital में अगर मान लो इतना हो रहा है, you take him to the OT ना. OT आप surgeons को दीजिए, उसको immediately you will take the OT and do the definitive care. So everything we don't have to do in the emergency. You have to involve the surgeons and hand them over. Okay? तो जितना आप कर सकते हैं. Pre hospital care में जहाँ कुछ नहीं होता है, ambulance में they keep the powders. Okay, like in the field. फील्ड में पैरामेडिक आ गया, ब्लीड हो रहा है, राइट, टूनिके बांध ली, वो तो वुंड बड़ा सा वुंड है, ही कैन pour this powders. In military setting they use a lot, the soldiers they have that in their pocket, so they have powder, then bleeding wound में डाल देते हैं, and that is life saving. So this is called hemostatic powder. Chitosin.
Is this the same as Centhaquin or something else? I
Pardon?
haven't. Role of Centhaquin in hemorrhage. Is this same?
Yeah, Centhaquin, these are all the hemostatic agents. है ना, Centhaquin भी है, Chitosin है, many are coming in the market, madam, now.
What is the chance of?
You will still feel that OT है. Hospital में इन सब की जरूरत नहीं है. Powder form का, you take him to the OT, hand over to the surgeons, they will do hemostasis.
What is the chance of fat embolism in road traffic accidents?
Yeah, the chances of fat embolism is high, especially if you have long bone fractures. है ना, young patient है ना, जिसमें fat content भी होता है bone में, so it is जैसे आपने जल्दी से उसको fix नहीं किया. Fracture femur में, shaft of femur में, I have seen many patients that they develop fat embolism, right? Because then how do you identify that? The patient will develop altered sensorium, means आपका conscious level alter हो जाएगा, and that is the biggest brain, which the brain involvement of the brain involvement of the lung में patient will have respiratory distress, saturation will be low. Okay, the third is you will find some retinal hemorrhages. Fundus examination करेंगे, the retinal hemorrhages भी दिखेगा. Platelet count will be low in case of fat embolism. So and you have to just do conservative management. So remember that diagnosing is clinical diagnosis is more important here. Because fracture femur mein there two things can happen. Same thing can also they can also develop DVT. Okay, proximal DVT, and it will dislodge. That also can cause pulmonary embolism. And same patient will have respiratory distress, right? And sometimes बोला can brain में उतना जाता नहीं है pulmonary embolism में if it is DVT. Okay, but fat embolism, the most important thing is altered sensorium. Okay, then respiratory distress. Then you do echo. कोई आपको देखना है कि right ventricular strain है या नहीं है. So management is also very conservative. You have to just do good splinting, early involvement of orthopedicians. They have to fix the bone early. That जल्दी अगर कर देते तो fat embolism develop नहीं होता. To prevent that is you have to fix the bone early. That means within 6 hours, 6 to 24 hours of injury, you should fix the femur, fractured bone. उससे fat embolism कम हो सकती है.
There was one question about snake venom anaphylaxis to snake venom. Nowadays, recommendation says no skin hypersensitivity testing before giving antivenom. You just give antivenom and watch this patient for if they develop any symptoms of anaphylaxis.
Right.
Usually, these are what do you call, I'm forgetting the name, वो थोड़ा सा रिगर वो राइगर्स हो सकते हैं, फीवर हो सकता है, so then you have to stop the infusion with anti snake venom and administer treatment, give treatment accordingly. So watching for anaphylaxis is more important than skin testing.
Correct.
Yeah, skin testing itself can cause anaphylaxis.
Yeah, it is not
So that
recommended.
is why it is not recommended.
Yes.
So I think that answers your question. And there is another question about the splinting in snake bite. Again, the take-home message is immobilize the limb.
Yeah.
That is very important. And if you suspect that delay is more than 3 hours before the patient can reach any health facility where anti-snake venom will be available, then only apply this. Otherwise, for other bleeding cases, I think he has amply explained, in detail how do you go about the applying this ligature. I hope that answers all the questions. Thank you, Dr. Sanjeev, for such a wonderful session. It just helped, I think, every one of us in refreshing it, prioritizing the treatment. I think in emergency, pre-hospital care, prioritization is something that we should know. How do you go about? Dr. Sanjeev, one last question from my side. Not a question, again, maybe you can explain once again, because whenever I do these, go to the peripheral health facilities, I see even in the tertiary care, in emergency, I see patients, when they see a patient of shock, they start with the IV line access, detailed history. They want to ascertain the cause of this shock. How do they prioritize management of shock? You don't know which kind of shock it is. So how do you go about prioritizing it?
Yeah. So the answer is whenever you say you get a case of undifferentiated shock, especially when the patient comes, so it can be either hemorrhagic, it can be distributive, it can be cardiogenic, it can be septic. There are 4 types of shock it has. So patient आपका आया undifferentiated है. So at least what you do is management, assessment and management has to go together. So suppose the patient is coming in, say, almost peri-arrest period. So start focusing on management first, So like ABC, do the airway breathing circulation. This is a mantra today I taught you, everybody. So follow the ABC model, okay? ABC. Okay. So after you've done the ABC model, then you look for evaluation. What is the
Sir, आप mute हो गए.
Just a minute, madam. Can you hear me, madam?
Now we can hear you.
So as soon as the patient comes to the
म्यूट हो गया.
Hypotensive, tachycardic, tachypneic, first triage him as red. Shift him to the resuscitation bay. Attach monitors, IV oxygen monitor. Three things you have to do. IV oxygen monitor for any sick patient. Second is first is management of shock. Immediately you start, managing the, patient hypotension. You will get history. Did he have any source of bleeding? It is hemorrhagic shock. You or patient has some say cardiac ailment, right? Cardiac ailment, chest pain, and now has come with shock. So that means he is a cardiogenic shock. So you don't have to give a lot of fluids. Or the patient comes with fever. कई दिनों से बुखार चल रहा था, and now has come with say hypotension. First thing you have to give fluids here. So putting a IV line does not mean हर एक में fluid देने का है. So put IV line, IV access, oxygen and monitor. So this is three things. So once you get a hypotension, basic thing आपने किया, like I said, after the IV oxygen monitor, do the ABC, ABC, ABC and ABC. This is for every patient. So this is the four conditions you have the shock. Fourth is the distributive shock. Sorry, obstructive shock. That is, you get pulmonary embolism or cardiac tamponade or tension pneumothorax. These are three causes of obstructive shock. तो जब आप एबीसी करेंगे तब आपको मिल जाएंगे ये सब. And how to assess? Do a, when you have shock patient, do a basic things like which you can do on the bedside is a ECG you can do. You can do a bedside chest X-ray if you don't have ultrasound or expertise नहीं है. Tertiary care level हमारे यहाँ पे what we do is most of us are trained in doing point of care ultrasound. That means you can find out the cause of shock, okay, undifferentiated shock. तो वो you can do a echo, तो उसमें ejection fraction कम मिलती है आपको, तो cardiogenic shock कहते हैं हम. ठीक है ना. तो बट हमारे डिस्ट्रिक्ट हॉस्पिटल उसमें अगर अनट्रेन हो, यू कैन डू बेसिक थिंग्स like chest X-ray, you can do a ECG. Clinical is you have to clinical acumen is the best one. सबसे बेस्ट क्या है हमारा क्लिनिकल acumen होता है. तो जैसे मैंने आपको बताया सेप्सिस में फीवर, patient will have fever and has cough, maybe source of pneumonia होगा. Now comes with hypotension, tachycardia, tachypnea, low saturation. एबीसी आप हर एक में एबीसी शुरू कर दीजिए, फिर हिस्ट्री लीजिए. इमरजेंसी केयर में एक चीज आप याद रखिए सब लोग. फर्स्ट यू थिंग इज फर्स्ट स्टेबिलाइज द पेशेंट. एबीसी करके आप स्टेबिलाइज करिए, एंड आफ्टर यू स्टेबिलाइज देन यू आस्क द हिस्ट्री. एबीसी एबीसी के लिए आपको ज्यादा हिस्ट्री नहीं चाहिए. आपको एबीसी एयरवे ब्रीदिंग सर्कुलेशन के लिए उसके बाद यू टेल योर कोलिग्स. अगर आप ये कर रहे हो, यू टेल समबडी टू टेक हिस्ट्री. You stabilize, then you come back and take the history, short history, then you go back and examine again. फिर आप डिटेल सर्च करिए कि क्या कारण है शॉक का. पहले तो शॉक मैनेज करिए, फिर कारण ढूंढिए, ना कि कारण ढूंढिए फिर शॉक मैनेज करिए. जैसे मैडम बोल रही थी पहले कि कारण ढूंढते हैं फिर शॉक मैनेज, तब तक पेशेंट लेट हो जाता है, मर जाता है पेशेंट, डेथ हो जाएगा, रेस्ट में चला जाता है. इमरजेंसी केयर का जो साइंस है उल्टा है थोड़ा सा. पहले आप देखिए जो भी इमरजेंसी रूम में आ गया, आप सोचिए कि ये पेशेंट अगले 10 मिनट में खत्म हो सकता है, अनलेस प्रूवन अदरवाइज, सिक पेशेंट. तो आपका मेन मंत्र ये होना चाहिए इमीडिएटली, अरे इसका एयरवे ठीक है, ब्रीदिंग ठीक है, सर्कुलेशन ठीक है, नहीं शॉक में है, एयरवे में प्रॉब्लम है, लेट मी इंट्यूबेट हिम. ब्रीदिंग में ऑक्सीजन लगा दूं पहले, जो प्रॉब्लम है उसका आप निवारण करिए. सैचुरेशन लो रहे ऑक्सीजन लगाएं, बीपी लो रहा है आईवी लाइन लगाएं. ठीक है ना. कोई जरूरत है नहीं जरूरत है देखेंगे, एक लाइन तो लगा लें. ठीक है ना. देन यू टेक ए कॉल कि व्हाट यू हैव टू डू. फिर देन यू गो बैक, हिस्ट्री जाइए, रिलेटिव्स के पास हिस्ट्री लीजिए, फिर आके क्लिनिकल एग्जामिनेशन करिए. मान लीजिए सेप्सिस है, कॉमनेस्ट कॉज होता है कम्युनिटी एक्वायर्ड निमोनिया, जिसमें सेप्सिस में जाता है. एल्डरली में है तो यूटीआई, यूरिनरी ट्रैक्ट इन्फेक्शन शॉक बहुत आता है. ठीक है. एब्डोमिनल इन्फेक्शन शॉक आता है. अल्कोहलिक्स में लिवर एब्सिस सेप्सिस में आता है. तो आपको कैटेगराइज करना पड़ेगा. किसी को कार्डियक एलिमेंट पहले से ही है, एक्यूट एमआई सीएडी का हिस्ट्री है, डायबिटीज में, तो दे आर मोर कॉमन फॉर हार्ट फेलियर. तो आप देखिए हार्ट फेलियर के सिम्टम्स क्लिनिकली आप देखिए, एक्सरे और ईसीजी तो है ही है, बट योर क्लिनिकल एक्यूमेंट, योर ब्रेन, योर स्किल, कोई चीज रिप्लेस नहीं कर सकता है, ना ईसीजी और ये है ना. कुछ भी नहीं होने से भी आपको आना चाहिए. तो ये करके आप शुरू करिए मैनेजमेंट. दैट इज व्हाट इट इज. एंड ट्रेन योरसेल्फ. नाउ आजकल कोर्सेस आ गए हैं बहुत सारे पॉइंट ऑफ केयर अल्ट्रासाउंड के. प्लीज यू कैन लर्न You can learn echo, lung ultrasound, है ना. और there is a protocol called as rush protocol, जो मैडम बात कर रही थी. अब मैं आ जाता हूँ थोड़े डायग्नोस्टिक्स पे. कैसे हम डिफरेंशिएट कर सकते हैं, जिसे हम कहते हैं रैपिड अल्ट्रासाउंड इन शॉक. फॉर अनडिफरेंशिएटेड शॉक हम कॉजेस ढूंढ सकते हैं. जैसे एको से आपको कार्डियोजेनिक लो इजेक्शन फ्रैक्शन, हार्ट पंप कम कर रहा है, इट कैन कॉज कार्डियोजेनिक शॉक. दूसरा, सेप्टिक शॉक से आप सोर्स पता लग सकते हैं. निमोनिया अल्ट्रासाउंड से पता लगा सकते हो आराम से. सो यू कैन फाइंड आउट द लिवर एब्सिस है, आराम से अल्ट्रासाउंड से पता लग सेप्सिस हो सकता है. सो यू कैन फाइंड आउट दैट. थर्ड इज, जैसे मैंने कहा कि ऑब्स्ट्रक्टिव शॉक. ऑब्स्ट्रक्टिव शॉक मैंने कहा कि पल्मोनरी एम्बोलिज्म उससे होती है. तो आराम से आप इको पे पता लग जाएगा कि इसको पल्मोनरी एम्बोलिज्म है कि नहीं. थर्ड इज टेंशन न्यूमोथोरेक्स. क्लिनिकली भी पता लगा सकते हो, जैसे अभी हमने पढ़ा. यू कैन, आप उसका निवारण कर सकते हैं. देन फोर्थ इज सॉरी कार्डियक टेम्पोनाड. वो भी ऑब्स्ट्रक्टिव शॉक है. तो आप, और टेम्पोनाड आए तो आप नीडल पेरिकार्डियोसेंटेसिस कर सकते हो. ओके, सो देन द लास्ट वेट इज हेमरेजिक शॉक. सबसे आसान इज हेमरेजिक शॉक. अभी हम पूरा हेमरेजिक शॉक ही 1-1.5 घंटे से पढ़ाई कर रहे थे. सो फर्स्ट स्टार्ट द ट्रीटमेंट, देन यू आस्क द क्वेश्चन इन इमरजेंसी केयर. ये आप अपना जो सोच है, जो भी हु आर वर्किंग इन द इमरजेंसी, डीलिंग इमरजेंसी केसेस, थोड़ा सा आप इसको ट्विस्ट करके ओपन लीजिए. जो सारे रेड पेशेंट है, क्रिटिकली इल और इंजर्ड, इसके बारे में ऐसे सोचना है. जो पेशेंट स्टेबल है, उसमें आप आराम से हिस्ट्री लीजिए, एग्जाम कीजिए, फिर ट्रीटमेंट करिए आप. लेकिन जो रेड पेशेंट है, सिक पेशेंट है, उसके लिए पहले आप ट्रीटमेंट करिए, फिर हिस्ट्री पूछिए. So this is the basic difference between the managing a sick patient and managing a not so sick patient. मैंने कह रहा हूँ कि ठीक है वो, लेकिन वो मरने वाले नहीं. ठीक है ना?
I think you've already, mass emergency में triaging is very important. How do you do that? He's asking about mass emergency. How do segregate which is to be prioritized?
Very good man. तो इसमें मास इमरजेंसी में मास कैजुअलिटी जैसे होती है. मान लीजिए आपके, एक तो होता है हमारा कलर कोडेड ट्रियाज होता है, रेड, येलो एंड ग्रीन, राइट. तो आपको देखना पड़ेगा कि कितनी मास कैजुअलिटी है. ठीक है ना. मान लीजिए आपके पास एक 30 बेडेड हॉस्पिटल है और आपके पास 50 पेशेंट या 60 पेशेंट एक साथ आ गए. सो इट इज अ मास कैजुअलिटी फॉर दैट पेशेंट, दैट हॉस्पिटल. और एक छोटा पीएचसी है जिसमें 2 ही बेड हैं, सडनली आपके पास 10 मरीज आ गए. तो इट बिकम्स अ मास कैजुअलिटी फॉर द प्राइमरी हेल्थ सेंटर. सेम मान लो 10 मरीज मेरे पास आ जाए एम्स में. 10 मरीज मेरे लिए कुछ नहीं है, नॉर्मल है मेरे लिए, वो मेरे लिए मास कैजुअलिटी नहीं है, बट वो प्राइमरी हेल्थ सेंटर के लिए मास कैजुअलिटी है. समझ रहे हैं. मास कैजुअलिटी का डेफिनेशन सब लोग अपना क्लियर करिए. ठीक है ना. कोई मान लो मेरे पास 30, मेरे इमरजेंसी में 40 बेड्स हैं. मेरे पास मान लीजिए डबल द नंबर आ गया, 80 आ गया, 100 आ गया, देन इट इज अ मास कैजुअलिटी फॉर मी. समझ रहे हैं. तो दिस इज कॉल्ड डेफिनेशन ऑफ मास कैजुअलिटी. हमें एक तो हम दुरुस्त कर रहे हैं. नंबर 2, तो ऐसे कंडीशन में नॉर्मली जब आप ट्रियाज करते हो, नॉर्मली देखिए आप क्या करते हैं. नॉर्मली एक इमरजेंसी में ट्रियाज क्राइटेरिया जो हम यूज करते हैं, द गवर्नमेंट ऑफ इंडिया का ट्रियाज क्राइटेरिया है, जो हमने एम्स ट्रियाज क्राइटेरिया बनाया था, वही अडॉप्ट करके गवर्नमेंट ऑफ इंडिया ने वी हैव ए अपना कंट्री का ट्रियाज प्रोटोकॉल है. इट इज बेस्ड ऑन कलर्स, रेड, येलो एंड ग्रीन. ओके. रेड मीन्स जो पेशेंट्स का एयरवे ब्रीदिंग सर्कुलेशन कॉम्प्रोमाइज्ड है. ओके. और सडनली पेशेंट आए चेस्ट पेन, सस्पेक्टेड एमआई, सीधा रेड हो जाता है. स्नेक बाइट, सीधा रेड हो जाता है. सो समझ रहे. जो सिक, क्रिटिकली इल और इंजर्ड है इन नट शेल, और उसका फिजियोलॉजी कॉम्प्रोमाइज, एबीसी कॉम्प्रोमाइज है, रेड. दूसरा जो येलो है, मतलब वो आप पूछेंगे अरे भाई कैसे हो, सर मेरे को दर्द हो रहा है, हड्डी टूटी हुई है, ही इज अ येलो पेशेंट. ओके. थर्ड इज, आप कहेंगे, तीसरा एक पेशेंट आएगा ग्रीन, कहेगा सर मेरे को जुकाम खांसी है, बुखार है ना सर, मेरे को लगा कि थोड़ा दिखा दूं, मेरे को उसके लिए इमरजेंसी है, बट वो बोल चाल रहा है और कोई सिस्टम नहीं है, उसको बुखार है, थोड़ा जुकाम खांसी है, या थोड़ा मेरे को सर ज्यादा यहाँ पे आज सुबह से इचिंग बहुत है, रैशेस निकल आए. या छोटा सा चोट लग गया, उसके लिए बहुत बड़ा इमरजेंसी है। लेकिन हमें हेल्थ केयर विभाग पता है कि इसका एबीसी ठीक है, तो भैया ये कुछ नहीं होने वाला, ठीक है ना, उसको मैं बाद में देखने से भी चले। लेकिन आप कह दोगे कि आप अरे थोड़ी देर वेट कर लो, तो आप पे चढ़ जाएगा वो, ठीक है ना, क्योंकि ही हैज द लंग पावर बोलने के, यही लोग ज्यादा चिल्लाते हैं, ठीक है ना, तो वो है ग्रीन पेशेंट, ठीक है ना मैम। तो कोई भी इमरजेंसी में रेड पेशेंट 10% होते हैं, येलो पर्सेंट 30% होते हैं, 60% ऑफ पेशेंट ग्रीन होते हैं, चलता फिरता मरीज, है ना, एक इमरजेंसी में। अब इसको ले लीजिए मास कैजुअलिटी में, ठीक है ना। मास कैजुअलिटी मतलब उस एक्सपोनेंशियली 3 to 4 टाइम्स द नंबर ऑफ बेड्स, है ना, फुटफॉल। नॉर्मल टाइम में, दिस इज माय एडवाइस टू एवरीबॉडी लिसनिंग टू मी, नॉर्मल टाइम में आप जाइए अपने डिपार्टमेंट में इमरजेंसी में ट्रियाज एस्टेब्लिश करिए पहले, ओके। एंड ट्रियाज हैज टू बी डन बाय ए नर्सिंग ऑफिसर, वर्ल्ड ओवर नर्सेस करती हैं। आप जाइए अपने नर्सिंग से बात करिए, नर्सिंग सुपरिटेंडेंट से या नर्सिंग हेड से, कि हमें इमरजेंसी में ट्रियाज लागू करना है, दिस इज द क्राइटेरिया, दिस इज हाउ इट इज डन। ट्रियाज रेड येलो ग्रीन कराइए और जोन्स बनाइए इमरजेंसी में, रेड येलो एंड ग्रीन जोन। ट्रियाज करके कहाँ ले जाओगे, रेड का रेड जोन में जाना चाहिए, येलो का येलो जोन में जाना है, ग्रीन का ग्रीन में जाना है। तो यही तो ब्यूटी है हमारे इंडियन जो ट्रियाज सिस्टम है, कम दिमाग अच्छा काम। अब आ जाइए मैस कैजुअलिटी में, 100 या 200 500 मरीज आए, तो 100 मरीज की बात कर रहे हैं, थोड़ा ज्यादा ही डबल आ गए तो आपको यही प्रोटोकॉल यूज करना है, ठीक है ना, रेड येलो ग्रीन। और एक कैटेगरी है ब्लू एंड ब्लैक। ब्लू बोले तो पेशेंट विल बी गैस्पिंग, ऐसे आता है ना गैस्पिंग, ऐसे करके आखिरी सांसें होती है, दैट इज कॉल्ड ब्लू। ब्लू मीन्स ब्लू और ग्रे कहते हैं, आप कुछ भी कर लीजिए वो बचेगा नहीं, ठीक है ना, दैट इज कॉल्ड ब्लू और ग्रे, जिसे हम कहते हैं नॉन सैल्वेजेबल पेशेंट। और लास्ट आता है ब्लैक, ब्लैक मीन्स डेड पेशेंट, ओके। सो ये अगर आपको मास कैजुअलिटी आ गया आपका, नॉर्मली आप ये करिए, मास कैजुअलिटी आ गया तो यही आपको फॉलो करना है। अगर आप रूटीनली आप ट्रियाज नहीं जानते हैं तो आप मास कैजुअलिटी में कर नहीं पाएंगे। व्हाट यू डू बेस्ट इन योर डेली लाइफ, you'll do, if I give 100 patients more, you'll do a good job. Normally आप नहीं करते, you cannot do. This is a hard statement, sir. Now I'll take it, madam, to 500. अब 500 पेशेंट आ गए एम्स ट्रॉमा सेंटर में, है ना, दिस इज कॉल्ड एज मास डिजास्टर, जो डॉक्टर साहब पूछ रहे थे, ओके। मास डिजास्टर या मास जिसे कहते हैं, है ना, जैसे बड़ा हादसा अर्थक्वेक हो गया, राइट, अर्थक्वेक में 1000 हजार, है ना, मेरे पास आ गए, मान लो 500 से ज्यादा मरीज आ गए, अब मैं क्या करूं। तो देयर इज अनदर ट्रियाज प्रोटोकॉल कॉल्ड एज WHO मास कैजुअलिटी मैनेजमेंट ट्रियाज प्रोटोकॉल। उसमें क्या करते हैं मैडम कि हम पूरे इमरजेंसी को रेड जोन में कन्वर्ट कर देते हैं, रेड ट्रियाज, ओके। क्योंकि 500 पेशेंट में मेरे को यही ढूंढना है कि, जैसे मैंने कहा ना, 10 to 20% रेड रहते हैं, उन 10 से 20% मुझे ढूंढना है ना, एक अथाह सागर से। 500 मरीज हैं, उसमें से मुझे 20% मरीज ढूंढने जो जिनको मैं बचा सकता हूँ, ओके। दे आर गोइंग टू डाई इफ यू डोंट ट्रीट देम, डोंट गिव मेडिकल इंटरवेंशन, दे विल डाई, समझ रहे हैं। 20% वो छुपे होंगे अंदर, ठीक है ना, 500 के मरीज में 20% आपके छुपे होंगे। अब ट्रियाज का बड़ा महत्व है। अब मैं क्या करूंगा, पेशेंट 500 आ रहे हैं, मेरे को इन्फॉर्मेशन मिला दिल्ली पुलिस से कि 500 आ रहे हैं सर आपके पास, मैं क्या करूंगा, बाहर एक सिक्योरिटी गार्ड खड़ा कर दूंगा, बोलूंगा कि जो मरीज पैदल आ रहे हैं, चल के आ रहे हैं, है ना, वो सारे ग्रीन है ना, ग्रीन में भेजूंगा, वॉक इन और नॉन वॉक इन। ट्रियाज कैसे का स्टेप 1 वॉक इन एंड नॉन वॉक इन। तो 500 में से जितने भी वॉक इन है, मैं एक एरिया बना दूंगा अपने इमरजेंसी के बगल में, एक एरिया, मान लीजिए एक कैंटीन है या खुला स्पेस है, उसको मैं ग्रीन जोन बना दूंगा। जितने भी वॉकिंग है मैं बोलूंगा तुम उधर चले जाओ, उधर एक टीम को बिठा दूंगा मैं, ओके। सेकेंड इज सिक्योरिटी गार्ड को ये बोलूंगा जितने नॉन वॉकिंग है सबको तुम इमरजेंसी में भेज दो, एग्जिस्टिंग इमरजेंसी। मेरा क्या काम है, पूरे इमरजेंसी को मैं रेड जोन में कन्वर्ट कर दूंगा। जितने नॉन वॉकिंग है मैडम चले जाएंगे इमरजेंसी में, राइट। उनको रेड की तरह मैं देखूंगा कि भैया सही में रेड है कि येलो भी है, इसके मिक्स होंगे। जिसका फ्रैक्चर लोअर लिम्ब का फ्रैक्चर है वो भी चल नहीं पाएगा, लेकिन रेड नहीं है, वाइटस ठीक है उसके। तो उनको मैं क्या करूंगा, शुरुआत में देख के जिसका वाइटल्स गड़बड़ है उसको रेड, ट्रू रेड की तरह ट्रीट करूंगा वहां पे। और जो फ्रैक्चर्ड है, चल नहीं पा रहे, उनको मैं येलो ट्रेज करके वार्ड में भेज दूंगा। हमारा येलो जोन मास कैजुअलिटी में कहाँ होता है? वार्ड में। वार्ड में मैं रेसिडेंट लगा दूंगा, डॉक्टर नर्सेस को लगा दूंगा, रूटीनली जैसे वार्ड चलाते हैं। वो येलो तो मरना नहीं है उसको, ना उसको पैदल चल सकता है, उसको इलाज होना है, थोड़ा टाइम लगना है, थोड़ा लेट भी करने से भी चलेगा, तो उनको येलो बना के वार्ड में भेज दूंगा। तो ऐसा होता है मैडम, जब मास डिजास्टर होता है 500 के ऊपर अगर होगा तो ऐसा करने का है, तो उससे सेग्रीगेट अच्छे हो जाते हैं एंड सेव्ड। उसमें हमारा मेन प्रिंसिपल होता है डू ग्रेटेस्ट गुड फॉर पेशेंट्स whom you can do by medical intervention, you can save the patient. अगर वो रेड को मैं मैडम ना करूं ट्रीटमेंट, आफ्टर सम टाइम दे विल बिकम ब्लैक, थोड़ी देर में ब्लैक हो जाएंगे, ब्लू और ब्लैक हो जाएंगे। ठीक है, वही तो हमारा काम है डॉक्टर्स का। ठीक है, ग्रीन को मरना नहीं है, ना येलो को कुछ होना है, ठीक है ना? खाली उनको जो मिक्सिंग में क्योस हो जाता है
हाँ,
उनको
पर सर ये ग्रीन वाले बड़े इमोशनली चार्ज होते हैं, तो उनको हैंडल करना भी बहुत जरूरी
बिल्कुल,
है।
दैट इज अ स्किल ऑफ फ्रंट लाइन। तो उसको अलग से कर दीजिए ना, मिक्सी मत होने दीजिए, अलग से उनको ध्यान रखना पड़ता है।
Even in usual emergency, you will find they are creating more ruckus in the emergency because they are all emotionally charged. Their caregivers
यस
are
मैडम,
also emotionally charged. तो handle उनको भी करना है, but then you have to prioritize how you.
उनके लिए अलग एक जोन है मैडम। ग्रीन का क्या है ना कि हम इमरजेंसी के अंदर आने नहीं देते ड्यूरिंग मास डिजास्टर्स। मास डिजास्टर मतलब 500 से ऊपर, तो उनके लिए ना इमरजेंसी के बगल में और एक एरिया चूज करते हो, खुला एक एरिया, वहाँ ग्रीन जोन बना दीजिए। कुछ डॉक्टर नर्स वहाँ दे दीजिए, स्मार्ट हैं, जो जो सीनियर और स्मार्ट हैं, सबसे ज्यादा वो हैंडल अच्छा करते हैं ग्रीन वालों को। थोड़े आप और मेरे ऐसे है ना ग्रे हेयर्स को उधर चले जाना है, समझ रहे हैं? तो हमारे को देख के भी थोड़ा शांति हो जाएगा उनका, और यंग बच्चे नहीं कर पाएंगे, तो उनको वहाँ पे स्मार्ट नर्सेज अपने वहाँ टीम बिठाइए, और वो जो 80% आपका ग्रीन है, 60% वो वहीं से ही अलग, दे विल नॉट मिक्स विद द इमरजेंसी डिपार्टमेंट, वो बाहर से ही बाहर उनका रास्ता भी एग्जिट अलग है होगा उसका।
That's a very good suggestion.
या सो यही मैडम डब्ल्यूएचओ एमसीएम कोर्स जब हम पढ़ाते हैं बच्चों को, यही पढ़ाते हैं।
अच्छा सर, ये जो ग्रे वाले हैं, जो ब्लू और ग्रे हैं, जो अब उसमें भी आई थिंक सिमिलर केयर गिवर जो फैमिली है वो भी बड़े चार्ज होते हैं। एंड इफ यू नो हमारे अपना ट्रायज प्रोटोकॉल में भी गिव प्रायोरिटी टू रेड वंस, एंड how do you manage that, so that there is no violence later or litigation later that they weren't given adequate care?
ओके ओके मैडम, इसका ऐसा है कि the major problem in our healthcare system is we are not training our staff into good communication skills. Okay, so neither in our medical आजकल competency based curriculum में आ गया है कि how to they're training young kids, young MBBS students, nursing students about how to have a good communication skills with the both interpersonal as well as with the family members. Now there is a concerted effort because communication skill is also equally important like a airway skill. How to manage shock. It is an important skill. तो हम इसमें ध्यान नहीं देते हैं. How to, आपका सवाल था कैसे how to do that. जो भी रेड पेशेंट है, even they are very sick, yellow, these patients are there. So what we do is, this red patient है बस या CPR इसका हो रहा है, तो वन ऑफ आवर जो डॉक्टर्स हैं इमीडिएटली या नर्स है इमीडिएटली हेल्थ केयर जो फैमिली मेंबर उनके साथ जाके बातचीत करते हैं। दिस इज कॉल्ड ए शॉर्ट बर्स्ट ऑफ कम्युनिकेशन। जैसे पेशेंट आया, देयर आर टू वेज ऑफ लिविंग, तो आप वर्बल एंड नॉन वर्बल कम्युनिकेशन करते हैं इसमें मैडम। तो जैसे पेशेंट मान लीजिए कार्डियक अरेस्ट आया हमारे इमरजेंसी में, तो इमीडिएटली हमारे जो टीम है, जैसे मैंने आपको पढ़ाया पूरे हमारे आज शाम को, कोड ब्लू और कोड रेड हम चिल्लाते हैं। जैसे पेशेंट आया कार्डियक अरेस्ट में, हमारा जो पोर्टर भी होता है, वो जो मरीज लेके आता है वहाँ एम्बुलेंस एरिया, वो चिल्लाता है कोड ब्लू, उसको सिखा रखा है हमने, तो चिल्लाते हुए आता है, तो हम लोग सब अटेंटिव हो जाता है, हमारा जो इमरजेंसी में बैठा रहता है डॉक्टर नर्स, तो फट से जाके अटेंड करता है ना, प्रोटोकॉल शुरू कर देता है। दिस इज कॉल्ड ए नॉन वर्बल कम्युनिकेशन। वो देखता है, मरीज भी देख रहा है कि उसके मरीज के साथ जो हेल्थ केयर टीम क्या कर रही है, या आने से किसी का रिस्पॉन्स नहीं है, बैठा हुआ है, मोबाइल खेल रहा है, ये कर रहा है या ये हो रहा है, या आते ही लोग उठ के दौड़ के चले गए मधुमक्खी की तरह. So that is what is a non-verbal communication. That is what we should train our everybody. Okay, team. Second is after you do that, madam, जो भी उनमें से टीम लीडर है या एक वो है, immediately you just speak to the resident. After जब काम शुरू करा के वो भी समझते हैं कि आते ही कोई नहीं बोलता मैडम, आते ही आप आपका काम शुरू कर देंगे, बेसिक स्टेबलाइजेशन करके आप बाहर आइए और फॉर ब्रीफ 1 मिनट या 30 सेकेंड आप उनको बता दीजिए कि क्या हो रहा है. उनको ये भी बोलिए कि आई विल कम बैक टू यू आफ्टर सम टाइम विथ मोर इंफॉर्मेशन. दोबारा मैं आके आपसे बात करूंगा ये, और यू डेलीगेट समबडी की इसको बीच बीच में थोड़ा थोड़ा बताते रहो, थोड़ा बताते, तो उससे में क्या था, एंग्जाइटी कम हो जाती है. दिस इज व्हाट इज कॉल्ड एज शॉर्ट बर्स्ट ऑफ कम्युनिकेशन. शॉर्ट बर्स्ट ऑफ कम्युनिकेशन, थोड़ा आप वो दीजिए, थोड़ा जैसे पानी पीते हैं वैसे ही उनको दीजिए. तो जो एंग्जाइटी होती है मैडम धीरे धीरे कम हो जाती है. उनको भी पता लगता है कि मेरे मरीज का ध्यान दिया. जब हमने ये करना शुरू किया तो हमारी जो वायलेंस है ये वाली है मैडम, ये नहीं कम हो जाती है मैडम. हमने सही पूरा चला जाता है बट 80% मिटिगेट हो जाता है. द मोर यू स्पीक, द मोर यू इन्फॉर्म द पेशेंट रिलेटिव, इट इज बेटर. फिर भी 10-20% तो वायलेंस होता ही है मैडम, ठीक है ना, बट 80% हमारे वी कैन मिटिगेट दैट. तो ये हमारा पर्सनल एक्सपीरियंस भी है और जो भी हम स्टूडेंट को यही सिखाते रहते हैं कि. और एक चीज है मैडम, शेयर डिसीजन मेकिंग. अगर मान लीजिए ऐसा कुछ प्रोसीजर है जिसमें हमें शेयर करना है, उनको बताना है, कंसेंट, शेयर डिसीजन मेकिंग, उनको बैठा के बताइए ये होने वाला है, उनके साथ डिसीजन लीजिए कई सारी चीजें. तो उससे भी मैडम ये वायलेंस नहीं होता. जहाँ वायलेंस कब होता है, जब आप बताते नहीं हो. और ये हम ये भी सोचते हैं कि यार हमारे पास तो कम टाइम होता है, इमरजेंसी में टाइम ही नहीं है बात करने के लिए. तो ये भी गलत है. ऐसा कुछ नहीं कि टाइम नहीं होता. हमारा वी आर रनिंग ए बिजी इमरजेंसी. अराउंड 700 डेली आता है मरीज हमारे इमरजेंसी में, एम्स इमरजेंसी में, और 200 आता है मैडम ट्रॉमा सेंटर में इमरजेंसी में. सो आपको वी हैव टू ट्रेन आवरसेल्फ कि दो, हम नहीं कह रहे कि लंबा बात करो. हमें पता है कि हमारे डॉक्टर नर्स के टाइम कम है, दौड़ दौड़ के काम करना पड़ता है इंडिया में. तो बट दिस इज कॉल्ड ए शॉर्ट बर्स्ट ऑफ कम्युनिकेशन. नॉन वर्बल एंड वर्बल. नॉन वर्बल बहुत जरूरी है. वो भी देखते हैं हार्ड मेहनत कर रहे हो आप तो मरीज के अटेंडेंट ही खुद बेचारे खड़े होकर वो करते हैं. तो दिस इज द थिंग एंड सो दिस आर सम ऑफ द टेक्निक्स मैडम.
Yeah.
पर देयर इज स्ट्रक्चर्ड कम्युनिकेशन टूल भी
Practical,
अवेलेबल
हाँ,
है, जिसे हम
practical
कहते हैं
है
इस
ना.
बार, इस बार
हम बिल्कुल बात नहीं करते,
कम्युनिकेशन पे एक सेपरेट.
एक्शन में
यस
रहते हैं
मैडम.
पर बात नहीं करते हैं, तो वो भी अच्छी बात नहीं है. पेशेंट्स के केयर गिवर्स को लगता है कि वी वर नॉट टोल्ड. तो इट इज वेरी इंपॉर्टेंट पार्ट ऑफ इमरजेंसी हैंडलिंग ऑफ द पेशेंट. अभी आई थिंक ये I think you have already answered this. When patient is brought to casualty with no life signs, how to handle such case? उसमें भी ब्रेक करना न्यूज इज ए इम्पोर्टेंट communication that we need to see. How do you break that news to the family? Again, senior person, you should show concern. That way it will help the in communicating these patients. बाकी वो ब्रॉड डेड और वो दोज आज सेशन बहुत लंबा हो गया, बट आई थिंक इट वाज वेरी यूजफुल सेशन. वी लॉस्ट डॉक्टर संजीव भोई's connection here right now, but I think he had already explained, given us very practical tools, and I think it will help us in managing our emergency cases better way. Referral is better and our patients get better. I think we will like to close. Next session is on what day, Ranjit? It is on heat related illness and heat stroke management.
madam.
Yeah. What is the day?
Yes.
Date कौन सा है?
Next STG webinar session will be on 20th of June, third Saturday. The topic is on heat illness and heat stroke.
Yeah.
And heat health related action at primary care centers.
I think the take-home message is follow treatment guidelines. The guidelines proper communication, proper documentation. These are very critical. You can all access the standard treatment guidelines. Many of you must have already got these. There are pathways for ICMR has made pathways for acute coronary syndrome and other. There are many pathways now. Our book is also there. This one is comprehensive. About 350 diseases, priority diseases have been covered. So, okay. And regarding Ranjit, can you tell them about the last session's certificate? Because many of them haven't got this.
Last session's the certificate we have not dispatched yet. By Monday or Tuesday, we'll declare the certificates.
Okay, don't worry. Anyway, it will. You will get it if you have attended this session. You have given both pre and post test. You will get it. Sometimes he also gets busy with it, and matching this with attendance, pre and post, all that takes some time. So please don't worry about this. Okay. Okay. Bye
Thank you,
bye.
madam.
We'll see you next session. Yeah.
Thank you.